afford to make. Okay, cannot afford to make. So 25-year-old with dysphagia, liquids more than solids, means you are thinking about achalasia. Correct? Dysphagia, young patient, more to liquids, you are thinking of achalasia. Now, when you think of achalasia, you will think of smooth tapering. Smooth tapering means bird beak. Okay, but let me also tell you that according to Bailey, even the rat tail is used in achalasia. So answer is rat tail deformity. This is the exact question from FMG exam. So don't say how. Exact, and this is given in Bailey. Now, you know what is corkscrew, right? Corkscrew is diffuse esophageal spasm. Where do you get irregular filling defect, carcinoma, esophagus? But why not B? Why not smooth filling defect? Okay, smooth tapering is not smooth filling defect. Filling defect means when the person consumes the barium, some part of the barium gets missed. So this is the barium and it goes around the lesion. That is a filling defect. So smooth filling defect implies what? It means benign tumors. Okay, like a leiomyoma. Leiomyoma is the most common benign tumor of the esophagus, right? So that was the answer. This is what you are seeing. This is a filling defect. This is the typical apple core appearance. Rat tail can be malignancy, yeah, it can be. This is apple core, CA esophagus. This is diffuse esophageal spasm, corkscrew esophagus. Okay. So a lot of people fell in this trap. Rat tail should be cancer, but rat tail can be achalasia also. Right. Patient with history of hematochezia undergoes a procedure as shown using the device. Okay, no, there is no smooth filling defect in those pics. Huh? उसमें नहीं है. What is the device? So hematochezia undergoing a procedure means he is having a hemorrhoid. Okay, likely to be a hemorrhoid. And इसमें लिखा हुआ है ना, barren band ligator. Answer is there in the image. Barren band ligator. So it is a pile bending kit. So don't say this was tough question. Picture में है, yes, picture में है. Still people got it wrong. Can you believe it? Despite that, people got it wrong. This is also FMG question. So this is a pile bending kit. These are hemorrhoids and these are the bands with which you will apply. This device is called a Barron's band ligator. It's not hemorrhoidectomy. Band ligation is not hemorrhoidectomy. Hemorrhoidectomy is an open surgery where you cut the hemorrhoids. Okay, so I'll show you. This is how hemorrhoids look when you do proctoscopy. Okay, and please don't say explain B option, say please explain B option. I mean, it sounds nice. Okay, don't demand explain B. You can say why not option B or please explain B. It just sounds nice. Why not hemorrhoid? Why not stapler? This is stapler. Okay, that's why not B. Okay, this is how stapler looks. The name of the stapler, anybody knows? What is the name of the stapler? It is called circular stapler. You should be able to identify it. Okay, this is a circular stapler. This is the stapling device. This triangular piece over there is called the anvil. Between the two, you are going to get stapled. Okay, the hemorrhoids will get stapled. Now you need to know what treatment is used for what hemorrhoids. Grade 1 hemorrhoids are those which don't exit the anus. Okay, they don't exit the anus. Grade 2 are those which exit the anus but return spontaneously. Okay, it means when the person stops straining, the hemorrhoid will go back. Grade 3 hemorrhoids are those which exit the anus but can be manually put back. Okay, they can be manually returned. So you can do some only what you like to do and push it back. And grade 4 hemorrhoids, they don't go back. Okay, now why you need to know? It's because the treatment is different. Grade A hemorrhoids, if they are, sorry, grade 1 hemorrhoids, If they are asymptomatic, then you do nothing. Then you just give the person laxatives. Okay, but if they are symptomatic or grade 2 hemorrhoids which are symptomatic, usually grade 2 are symptomatic. So grade 1 hemorrhoids symptomatic or grade 2 hemorrhoids. For these two, you are going to use either bending, like I showed you in the picture, or you can do sclerotherapy. Okay, either you can do bending or you can do sclerotherapy. Means minimal surgical procedures. Any other disease where you have done bending or sclerotherapy? Any other disease? Yeah, esophageal varices. You do the same there. You do endoscopic bend. Okay, there it is endoscopic. For higher grades, you have to do surgery. Okay, which can either be this stapled surgery or you can do Milligan-Morgan. That is open hemorrhoidectomy of Milligan-Morgan. So these are the two surgeries, fine. So that is why the answer here, if I ask you for what grade this is going to be used, it will be for grade 2 or grade 1 with symptoms, fine. Okay, hemorrhoids look like this. They look nothing like a rectal prolapse. They are purple, vascular, bulging masses which present with blood in stools. Rectal prolapse does not present with blood in stools. Rectal prolapse presents with the mass coming out per anus. So they are not at all similar, by no scope of imagination. Okay. 4-year-old boy was brought to the ER. He had intermittent pain. He had black tarry stools. Even without the image. Chalo, let's say you don't have the image because the image you could not understand. Without the image, you should be able to give the answer. Treatment of thrombus piles is you have to excise them. You have to excise them. So, 4-year-old boy with the black tarry stools means he's having bleeding. Bleeding in a young child in the first decade of life without anything is going to be Meckel's rheumatoid, which corroborates with the image. Why is this not appendix? Why it is not appendicitis? Why it is not appendicitis? It's not obviously obstructed bowel loops. That is so easy to understand. Mesentery, anti-mesenteric, no cecum. Please understand, appendix arises from the cecum. This is the cecum. Appendix comes like this. Okay. And at the base of the appendix, you will see the tinea coli. This is not cecum. This is small bowel. You can see this. This is small bowel. This is the part from where the blood vessels are going. That is the mesenteric side. Okay. That is the mesenteric side. Fine. So that is why it's a bulge on the anti-mesenteric border. So it is a Meckel's rheumatoid. Fine. Good. Meckel's is painless or painful. Bailey says painful, but it can be either. Okay, it can be either. It's not necessary. Okay, because the person gets ileal ulcers. But the thing is, a 4-year-old child may not be able to explain that he's having pain. That is the reason. He may not be able to explain. Okay, right. Now see, patient has the swelling. These are varicosities. Which of these is incorrect? Radiofrequency ablation can be used for treatment is correct. Saphenous vein is involved. Why it is great saphenous vein? What other vein is involved? What other vein can be involved? Sural करके कोई vein नहीं होती है. The other vein which can be involved is the short saphenous vein. No, don't say femoral vein. It's either great saphenous or short saphenous. Why it is not short saphenous? Great saphenous is on the medial side, correct? This is the great saphenous. It goes all the way till the thigh. Where is short saphenous? Where is the short saphenous? It's not lateral. Short saphenous is posterior. Okay, it starts laterally, but it goes posterior. Okay, so this is correct. Compression stockings provide symptomatic benefit. Is correct. Fasciotomy is not a part of Trendelenburg procedure. Okay, it's not a part of Trendelenburg procedure. What is this procedure? Trendelenburg. What do you do in this? Very nice, Himanshu. You do a flush ligation of great saphenous vein. Flush means it is ligated flush with the femoral vein. And then you do stripping of the great saphenous vein. Full stripping, full strip. Okay. You do stripping of great saphenous vein. That is Trendelenburg procedure, not done very commonly nowadays. Now, what is preferred is either you do radio frequency ablation or you do what I told you, EVLA, endovenous laser ablation. They are the same. Only either you use laser or you do radio frequency. Only the device is different. Technique is the same. Okay. See, flush ligation means I am drawing a big thigh and a big leg. Don't say elephantiasis leg. Okay, don't let your imagination run wild. This is the great saphenous vein. Okay, and I'm showing a big dilated great saphenous vein. It joins the femoral vein, saphenofemoral junction. And when I say varicosities, it is because there is reversal over here. Right, it reverses. That is why you say it is varicose. Flush ligation means you ligate the great saphenous vein at the saphenofemoral junction and then you strip it. Okay, then you take out the. That is the meaning of flush, not the bathroom flush, not the facial flush. Flush means at the same level. Okay, yeah, normally you strip only up to knee. Why not below the knee? Why strip only up to knee? Whatever Ashleelta you are thinking, don't think about that. Why strip up to knee, not below? Because there is higher risk of injury to which nerve? Risk of injury to? Okay, don't say saphenous. It is, don't say sural, it is saphenous nerve. Great saphenous vein, saphenous nerve. Okay, it is saphenous nerve. Okay, not sural nerve. Sural nerve is in short saphenous vein. Yeah. Okay. Patient presents with a diffuse contaminated peritonitis. After laparotomy, this is what happened. What is this? What has happened here? Yeah, this is burst abdomen. Also called as wound dehiscence. Salmon pink fluid. Correct? That happened just before. So what do you do in this case? The patient can be managed next by immediate suturing. No. What do you see in this wound that is telling you you should not suture it? No, you don't really see. You're not seeing it in the photo. What is this white thing that you're seeing? Very nice. That white thing. It's called slough. Okay, slough is a marker of infection or non-healing of a wound. If it's non-healing, what do? You have to make it healing. To make it healing, you will do a vac dressing. So what will happen with the vac dressing? It will start healing after 5 to 7 days. And after it starts healing, you can do a suturing or you can do a skin graft, depending on how big the wound is. आई बात समझ में? So the advantage of vac dressing is non-healing will become healing. That is the message. Okay. Once it becomes healing, then you can do either suturing or you can do a skin graft, depending on how big the wound is. That is the premise of the question. What is this? This. That little thing in between. Can we just apply, remove slough, clean wound, and then apply? No. Just removing slough will not make it clean. It has to start showing granulation. That is the meaning. That thing you are seeing that I have marked, that is the viscera inside. That is the bowel. This is the bowel underneath, which is popping out. Okay, fine. So when we use flaps, flaps are not used for these kind of wounds. Flaps are used for large wounds. How is a flap different from a graft? How is flap different from graft? A flap is something that carries its own blood supply. Okay, it has its own vascularity. Skin graft did not have its blood supply, so it got the nutrition from where you placed it. That is a skin graft. Flap will get the nutrition from its source. So if it is attached to the source, like this flap, the first one, it's a local flap. You have a hole over here, a defect. To fill this defect, you are taking a piece of tissue adjacent, turning it around, and filling the gap. What flap is this? This flap. This is the Limburg flap, used for pilonidal signs. So one is local. Take the tissue from adjacent area, turn it, put it on the gap. Okay, this is not Z-plasty. Z-plasty is for contractures. Then you have pedicle flaps. Pedicle means the flap is away from the source, but it is attached via vascular pedicle. What is the flap in the photo? What flap is this? This flap, what you are doing, you are taking tissue from the shoulder, it is a flap, and putting it on the face. But the blood supply is coming from the same source. So this, what was supplying the shoulder flap, is only supplying the face. This flap in the image, this is a deltopectoral flap. Similarly, you have PMMC, pectoralis major myocutaneous flap. That is PMMC. And then you have free flaps. In free flaps, you do a vascular anastomosis. So from where you took the tissue and where you attach it, you have to do artery to artery, vein to vein anastomosis, like this one, where I've cut skin, subacute, fascia, muscle, bone, taken that with the blood supply, put it on the face, did all the joining. So this type of a flap is a free flap. The one in the image is free fibular flap. Okay, it is free fibular flap. You use it after head and neck for head and neck reconstruction. Right. So these are the types of flaps. In the class I taught you graft. Here I am teaching you flaps, so that most of the plastic surgery automatically gets covered. Okay. Young patient like you, painless testicular swelling. Left testis is normal. There are enlarged paraortic nodes. Right testis shows a mass. What do you think is the mass? Why from fibula, not from thigh? You mean you want to take femur? Then what will you put in its place? Fibula you can take. Fibula is not maid bearing. Abhi orthopedic hua hoga. Femur you can't take. Okay. Please don't do anything to the femur. It is the strongest bone in the body. This is likely to be a seminoma. Likely. Seminoma with para-aortic lymph node mets. So the next step is going to be high-inguinal orchidectomy. After high-inguinal orchidectomy is when you are going to do PET scan or CT scan, and then you are going to do the TNM staging. Okay, and then decide the treatment. Scrotal orchidectomy is contraindicated because you will upstage it. You don't do biopsy, you don't do scrotal orchidectomy, you will upstage it. The tumor will go from testis to scrotum. Biopsy of para-aortic lymph nodes can be done later. Not really needed, can be done later. Biopsy is also contraindicated. Okay, no biopsy, no scrotal exploration. Frozen section na, frozen section na, agar doubt hai. When you see when you deliver the testes, if you feel it is not a seminoma, then you can do Shevasus. Cut, take a piece. Yeah, if whether lymph node involved or not, next step is high-inguinal orchidectomy. Then you see whether you need to do, whether it's a malignancy, whether you want to do PET scan or not. Next step is high-inguinal orchidectomy. This is a PYQ INI-CET and PYQ FMG. Two places it has come. This I taught you in class, and this is a FMG PYQ. Very nice question. The FMG students unfortunately did not understand. They did not understand. So even the recall for them was difficult. I had to ask 10, 12 students, what did they exactly say? Then I understood, oh, this is what they meant. Because they kept saying 1 lumen, 2 lumen, 3 lumen, 4 lumen, 1 lumen, 2 lumen, 3 lumen, 4 lumen. So like, relax. Like how I have to tell you guys, na, relax. Don't jump the gun, use your brains. So I have to tell them the same thing. But only difference is then they relax. Most of the times. With you guys, I can't say. You guys only do time pass. So multiple clots in urine. What will you do to irrigate? Normally, you use 2 lumen. This is your normal catheterization you must have done in life. 3 lumen is for irrigating clots, like if you have done a TURP. The third lumen helps in irrigation. So one is to drain the urine, one is to irrigate, and one is to inflate the balloon for making it self-retaining. Ever use 1 lumen catheter? Single lumen Foley's? No. Is there a single lumen Foley's? नहीं SPC में भी double lumen ही use करते. It is used for single drainage, one-time drainage. Not commonly used, huh? Not commonly used, but for single drainage. Like you are doing a surgery went on for very long and you want to drain the urine one time, you can do it. Single time drainage. 4 lumen catheter, at least I do not know. I have never heard of a 4 lumen catheter. At least it is, no. There you want it to be there because you are going to drain it. First you will put, then you will drain. Then how would it be kept in place? No, single drain means put, drain, remove. Then it is not self-retaining. Again, think before you ask the question. Huh? Single time drainage means I don't want to retain it. It will keep the thing sterile. You keep catheter for 4-5 days, then the sterility is best. So you will not prefer. आजकल मिलते नहीं. आजकल you only get double lumen, even if you want to put single time. Which of these is correct about pair in the management of hydradid? It stands for percutaneous aspiration. This should be correct, no? What's wrong with this? No, it is puncture. I thought many of you will see A and mark. Okay, I thought many of you will A dekh ke mark. Because many of you would not be, oh, percutaneous knee puncture knee percutaneous. No. It can be performed for pulmonary hydatids. No. Pulmonary hydatids have to be treated by surgery. Prior treatment with albendazole is correct. Cystobiliary communication and honeycombing are contraindications. So this is wrong. Okay, it is wrong. Cystobiliary communication में नहीं कर सकते आप because the sclerosant will go in the bile duct and cause cholangitis. Okay, which of these is true regarding highly selective vagotomy? Puncture is done percutaneously though. In pair, yes. So if you'll see Sebastian, na, he says puncture, he says percutaneous, but Bailey says puncture. Oops. Bailey में भी दिया है puncture. Sebastian में percutaneous ही दिया है, but Sebastian से question नहीं आएगा ना. So it is the procedure of choice for gastric ulcers. No, it is done for duodenal ulcers. Pyloric nerves of Latarjet are preserved. And because they are preserved, drainage procedure is not required is correct. It does not have low recurrence, it has a higher recurrence. Compared to other procedures, the recurrence is higher. But yeah, drainage is not required. Drainage is required in truncal vagotomy because there the pylorus will become spastic. So, important table about the recurrence rates and complications. Highly selective vagotomy, least mortality, least side effects, best tolerated. Okay, best tolerated procedure, highly selective vagotomy. But recurrence little higher, little on the higher side. Latarjet is same as no. Latarjet are the branches of the vagus. This is not vagal trunk. Vagal trunk is truncal vagotomy. And combined procedure, vagotomy and enterectomy, maximum side effects but least recurrence. It is the most powerful. So most powerful is combined procedure. Okay, most powerful is combined procedure. So treatment for gastric ulcers is not these procedures. For gastric ulcers, you resect the ulcer if you are doing surgery because it can be malignant. For duodenal ulcers, you do vagotomy, either truncal or highly selective. In truncal vagotomy, you have to put a drainage procedure. In highly selective, no drainage is needed. Or you do antrectomy. Okay, antrectomy will take care of gastrin, it will reduce the acid. So these are the main procedures. Combined will be most power, but they are all done for duodenal ulcers. Or if I'm saying Johnson type, type 2, type 3, Johnson type, because they are associated with increase in acid secretion. Crow's foot versus Latarjet. Any difference? No. Latarjet are all the nerves, means all the branches. Okay, all the branches which are arising from the entire posterior vagus are called nerve of Latarjet. Crow's foot are the seromuscular branches going to the pylons. Hardcore anatomy question. That was by Ravi. 45-year-old man with chronic alcohol use with hematemesis after binge drinking. Forceful vomiting. GI shows linear mucosal tear at the GE junction. This is a Mallory stare. Right? This is a Mallory stare. Usually, Mallory stare will stop by itself. No, not Deulofoy lesion. Deulofoy lesion is a vascular malformation which is bleeding in the fundus. This is after forced vomiting, after alcohol binge. This is Mallory stare. Answer is self-limiting. Most of the times. Okay. Sclerotherapy and bending are used for varices. Dual endotherapy is used for peptic ulcer. Okay, peptic ulcer. That's where you'll use dual endotherapy. Fine. Okay. In variceal bleed, after you stabilize the patient, what do you do first? You did the ABC Ryle's tube, you aspirated the blood. Yes, it is hematemesis. What do you do first? What is the first step in variceal bleed? Yeah, it is not endoscopy. It is pharmacotherapy. Remember this. It is pharmacotherapy. So you even before you do endoscopy, you give IV terlipressin or octreotide. Terlipressin is preferred. What will this do? This will reduce the portal pressure and the varices bleeding will stop. Next step is going to be endoscopy. And in endoscopy, the varices look like this. Last year NEET question. When you apply a band, the status post banding looks like this. So endoscopically, you can either do banding or you can do sclerotherapy. 90% patients, the bleeding will stop with this. 90% patients. Very few patients, you'll have to do something more, which is what I asked in the next question. That is this. See, even the system of the question had some meaning. They were not randomly picked from here and there and just bombarded on you. Because in the back of my mind, there were topics which I wanted to discuss. And in the back of my mind, I didn't want to put all easy questions and all difficult questions. It had to be a mix. Because that's how exam is going to be. So, which of these is not a part of emergency management? It's not propranolol. Propranolol tablet, not IV, is used for prophylaxis. Okay, it is used for prophylaxis. All the other things can be used. Where do you use this? Endoscopic glue. ये glue का use होता है means you will use banding or sclerotherapy. Where will you use glue? Tips in emergency. Of course, it can be done very much. Can be done. It was invented for emergency only. Endoscopic glue, where is this used? How it is different from sclerotherapy and band ligation? Is it used for varices? Remember, it is used for gastric varices. Not everybody has esophageal varices. Some people have collaterals in the stomach. For those collaterals, you can't use this band ligation. because your endoscope will not reach till there to put the band. So for gastric varices, you do glue injection. What glue is used? Any idea? What is the glue? It is a cyanoacrylate glue. No. Tetradecyl is sclerotherapy. That is sclerotherapy. This is cyanoacrylate glue. Okay. I didn't put it ना. That's why it is not MS level. What I'm telling you is INI-CET level. इसलिए तो मैंने डाला नहीं वो, वरना मैं डाल देता cyanoacrylate glue. So if bleeding is not controlled by endoscopy, then your other options are balloon tamponade. Okay, you can do a balloon tamponade, which looks like this. So you put this balloon. What balloon is this? Always see how many channels are there. Okay, always see 1 channel, 2 channel, 3 channel, 4 channels. 4 channels is Minnesota. Okay, if there are 4 lumen, it is Minnesota. 3 lumen in SBT. So you put it, you inflate this, the gastric balloon with 300 cc air. If need be, esophageal balloon with 40 cc air. And you keep it. But see, these tubes can be kept for a maximum of 24 to 36 hours. They cannot be kept forever because they cause pressure necrosis. If the person still has bleeding, you can do tips. Okay, yeah, 30. In the image is 40, 30 and 300. That's why I teach it like that. 30, 300 becomes easier to remember. Okay, so Rohan Tyagi, don't make that wala face. Okay. Can we take another endoscopy trial? You can, but normally endoscopy did not stop the bleed. Normally you'll know it. So tips, what it will do, it is a stent. It is put by radiologists between hepatic vein and portal vein branches. Transjugular intrahepatic portosystemic shunt. Exam mein they will ask you complication. Early complication most common is hepatic encephalopathy. Because the stent will bypass the liver. The blood will go, it will bypass the liver. And most common late complication, which is also the most common overall, is stenosis or stent block. 50% of the cases, the stent will block. Okay. Transjugular intrahepatic portosystemic shunt. No, if he has hepatic encephalopathy, no, then you would not do. Does we want to remember? No, not for NEET. Definitely not. Selective, non-selective. Like you can learn, it's not difficult, but they are not commonly done also in today's day and age. Everybody will do liver transplant. They won't do shunts. Which of these procedures is performed for rectal cancers? What is Ripstein? It is for rectal prolapse. Mesh rectopexy. That is Ripstein. Rectal prolapse. Milligan Morgan. Open hemorrhoid. We just did that. TATME. It stands for transanal total mesorectal excision. So if I don't want to do an abdominal surgery, if I just want to do an endoscopic surgery, I can do it like this. What type of procedure is this? Total mesorectal excision. I am not doing it abdomen. I am not doing it perineal. Yeah, very nice. It's an endoscopic procedure. It's a Notes procedure. Natural orifice surgery. Dolmen, you know, ENT topic. Sinker's divertical. Okay, so that is for Sinker's divertical. I am sure. No, TME preferred over resection. TME is the principle. That is a principle of surgery. Total mesorectal excision. That means you are doing a radical rectal resection. It's not the name of the surgery. Patient with chronic constipation, antipsychotic use, Severe abdominal pain, distension, obstipation means he's having intestinal obstruction. Bent inner tube sign, sigmoid volvulus. I didn't put coffee bean, I didn't put image. I wrote chupake, bent inner tube sign. If you saw it, you will get the answer. Most people will think laparotomy. Some people will think high pressure enema. Is it used? High pressure enema? Is it used? No. Please remember, high pressure enema is for intussusception. Okay. कुछ भी कहीं मत टिका देना. It is for intussusception. Answer is CT abdomen. Then decide. If no ischemia, then you will do colonoscopy. Colonoscopic decompression. If ischemia, yeah, or you can put flatus tube. If ischemia, then you will do sigmoidectomy. Okay, then the answer will be sigmoidectomy. If asked best step, can we mark A? I will say yes, you can mark A, but it doesn't make sense, no? Means that it's a very bad question. That they are not giving you the clear-cut diagnosis. They are not even telling you whether there is ischemia or no. You know? So you can mark A, obviously, but then I would not recommend you to think like that. Means then, even if they have not asked best step, you will still mark A. Yeah. So I would not recommend. Tympanic abdomen means the bowel is full. That's why tympanic. Is Hartmann used? You can use it. Yes. Okay. Right. This, I think, was one of the finest questions of this paper. Is it coffee bean and bent inner tube tire are the same? They imply sigmoid volvulus. I am sure many of you would have marked the wrong answer. I am sure. Okay. Because this question I created by fluke for the FMG students. Means I was discussing it with them and I saw that I asked something and they answered something else. I was like, oh, okay, let's revamp it. So this is a revamp question. Patient has a breast cancer. It is 6 by 4 centimeters. You want to know the T stage, right? So 6 centimeters means more than 5 centimeters means T3. Skin ulceration means T4B. अगर पता चला, क्या पता चल गया? इश्कीमिया है कि नहीं पता नहीं चला ना दोस्त, उसके लिए सीटी किया है, नहीं पता चला. Fixity to pec measure doesn't affect, but fixity to ribs is going to be T4A. So people will think I should mark T4B because take the higher stage, na? Or some people will not see ribs, so they will still mark T4B. But it is T4A plus T4B, that is T4C. So both are present, it is A plus B C. ये बात पता है. When we give the exam, we think we got the answer. अरे so easy. तो बहुत easy था. Then when you will give me recall, you will say, sir, बहुत easy था. And when I will discuss it in the recall, I will say such an easy question, but it was never an easy question. So then it looks bad upon me. Because then other surgery teachers will say, sir, कुछ भी recall दे. Right? Who's at fault? Me or your lack of understanding? Or both? So that's why when I take recall, I ask, are you sure this is what was the line? Are you sure? Was it this? Was it that? Okay, but you have to, it's a part of the deal. Can't help it. गालियां तो पढ़नी है. कुछ भी कर लो. Right. So which of these is true regarding burns? This was an easy question. First degree burns involve epidermis and dermis with blister formation is known. Blister formation is seen in superficial partial thickness. Yeah, you will consider it as less than 1/3. If they want you to mark inflammatory, then they will tell you it is inflammatory somewhere. Parkland formula for calculating burns using crystalloids and colloids is false. It is only crystalloids, only ring-elected. Full thickness burns are associated with eschar formation. Is true. Easy question. Inhalational burns can, ये क्या है? ये क्यों गलत है? Inhalational burns can lead to laryngeal edema immediately after burns. Why not D? Because it's not immediate. It is usually after 4 to 24 hours. So the teaching is, when you get inhalational burns, you don't get the edema immediately. So when you reach the hospital, you're okay. Surgeon will think nothing, there is no wrong, nothing is wrong, but you should still intubate. Because if they develop edema, then you can't intubate. Then you have to do front of neck access. So you do prophylactic intubation. Correct? Yeah, correct. Ayush Gandhi. Yes. These patients have to be referred to burn center. This question I put because someone messaged me that sir ये topic discuss करना. So this is at request. I forgot her name. I think it was Sangya. I'm not very sure. So one person asked me, sir ये थोड़ा डालना. 30-year-old male presents with recurrent abdominal pain. जो भी वो नेक इंसान था, I hope he is listening. हाँ, संज्ञा ही थी. Okay, याद रहता है मुझे थोड़ा थोड़ा. He also reports weight loss and occasional blood. Colonoscopy reveals cobblestone mucosa, whatever. Which of the following findings are typically seen in Crohn's? This is a similar question was asked in INICET last year. Similar question. It had very, gooey free language. So what finding is seen in Crohn's? Not in ulcerative colitis. See, Crohn's and UC are both inflammatory bowel, but they are very different. Actually, they are not same. Apart from being inflammatory bowel disease, there is nothing similar in them. And I always tell you, Crohn's and TB are similar, not Crohn's and ulcerative. They are not at all similar. High risk of skin lesions like pyoderma. How you are getting skin lesions in either in Crohn's or ulcerative colitis? Are you getting skin lesions? What are these skin lesions? Autoimmune. Yeah, these are extra intestinal manifestations. And they are seen more commonly in Crohn's. Skin lesions are more common in Crohn's. This is correct. Okay, skin lesions, pyoderma, erythema nodosum are common. It's a part of the inflammatory process. Yeah, erythema nodosum, correct. Eye lesions, iridocyclitis, common and more common in Crohn's. Ulcerative colitis not so common. Ulcerative colitis you only get arthritis, arthralgia. That is what you see. Okay, continuous involvement is seen in ulcerative colitis. Superficial inflammation, ulcerative colitis. In Crohn's, it is skip lesions. In Crohn's, it is deep lesions. And higher risk of colorectal cancer, again, more in ulcerative colitis. Okay, so easy. P. ANCA and sclerosing choline, yeah. P. ANCA and biliary diseases are more common in ulcerative colitis. So simple, I'll give you a simple trick to remember. Difference between Crohn's and ulcerative colitis. Okay, simple trick. I give it to my students always. Crohn's, the correct name is Crohn's regional ileitis. Ulcerative colitis, the correct name is ulcerative proctocolitis. Just remember this. Half the battle is done. Regional means affects some parts. It will not affect the full body, not the whole GIT, some parts. So it will affect any part of GIT. But most commonly, the ileum, terminal ileum, just like tuberculosis. Now, ulcerative colitis is actually proctocolitis. Procto means rectum. The disease always starts in the rectum, always. And continuously spreads proximally. Okay, it will continuously spread proximally. So it starts in the rectum, rectum to sigmoid, sigmoid descending करके full colon. It will never have skip lesions. So this is the basic pattern. Skip lesions. इतना समझ गया ना regional ileitis, continuous involvement. If you do colonoscopy, then on colonoscopy here you will see ulcers, abscess ulcers, cobblestone mucosa. That is ulcerative colitis. Sorry, that is Crohn's. Ulcerative colitis, what will you see? Appearance, very typical appearance of ulcerative colitis. Starts with a P. No. Lead pipe. It's not lead pipe. Lead pipe is on X-ray. You see pseudo polyps. They are inflammatory polyps. Microscopy transmural. And you will see granulomas. and this is going to be superficial. Only superficial inflammation, not transmural, which is also called as cryptitis. Only the crypts are inflamed. Cryptitis, crypt abscess. That is what is in ulcerative colitis. Complications here, since it is full thickness, stricture, perforation, perianal Crohn's, multiple fistulae. Ulcerative colitis, CA, more risk, colorectal cancer, toxic megacolon. बस हो गया काम. ट्रीटमेंट दोनों का सेम ही है, immunosuppression. Job is done. No, risk of colorectal cancer is much higher in ulcerative colitis and it increases with age. Crohn's does not affect rectum, it affects anus, it affects ileum. Ileum में normally cancer नहीं होते, है ना? Normally cancer नहीं होते ileum. This was a trick question. 7-year-old boy concerns about elevated right testes after returning from school. Fistula and Crohn's. On examination, testes is higher. So this should be undescended testes, no? Testes is higher. Why it is not undescended? Because the scrotum is well developed, which means something happened in school. किसी ने उसको मारा होगा या टीचर ने चिल्लाया होगा, घबरा गया होगा. Intense cremasteric response. Testes went up transiently. That is retractile testes. No, not thigh stroke in school नहीं. ये accident नहीं होगा, accidental doctor. ऐसी चीजें नहीं होती स्कूल में, होनी नहीं चाहिए. So this is retractile testes. How will you confirm? Scrotum is normally developed, which is fine. How will you confirm that it is retractile? Means how will you ensure that it comes down later? You do a test. Shivam is saying correctly. That is called Orr chair test. So you make the child squat on a chair. When he squats, the testes will descend. Obviously, an undescended testes, ectopic testes is not going anywhere. It will remain where it is. Okay, that is called Orr chair test. Or you just give him analgesics, and over time, after a few minutes to hours, it will come back. But the fact that the scrotum is well developed means it is not undescended. Okay, so this was a trick question. Such a traumatic day. What is this word? Cryptorchidism? Strange Supreme is asking. What is this cryptorchidism? Is it same as undescended testes? No, it is not exactly the same. It means the person has bilateral missing testes. Okay, undescended could be, but undescended should not be palpable. Means you cannot feel them in the groin. It should be missing testes. So maybe they are in the abdomen. Maybe they are missing. Means they are not developed one. That's also possible. But they should not be palpable anywhere else. That is the correct meaning of crypto. You know what is crypto, na? Crypto is something that you can't see. Like if you do cryptocurrency, you don't know where your currency is, na? It's राम भरोसे. आज है कल नहीं है. Cryptorchid testis, same. आप लोग बहुत माहिर लोग हो इन चीजों में. I mean, I should be asking you for all these things, but yeah. So in none of these conditions will the scrotum be developed. Okay, in none of the conditions will the scrotum be developed. Okay. Do we give injection? No, that is only if you are having doubt in location. You can't locate it, then you can give. Like if you do CT scan and you can't find it, then you can give. But the crypts have your currency. But you don't know na, what happens. आज है कल नहीं है. What type of hernia is this? I am sure many of you would have marked Richter's hernia. I am so sure. So this is a defect. And please see from the defect, this is not what is coming. This is what has gone out. 2 loops of bowel. That is middle hernia. Okay. 2 loops of bowel. That is middle hernia. What is pantaloon? Means on the same side, I showed you the photo of this pantaloon. On the same side, the person has direct plus indirect inguinal. On the same side means he has two defects on the same side. Richter, only knuckle of the bowel forms the content. Only knuckle, only circumference. What is amide? Inguinal hernia containing appendix. So inguinal hernia where the content is appendix is amide hernia. Litter's hernia, Meckel's diverticulum. 58-year-old with history of diabetes underwent TURP. He now has absence of semen. Happens during ejaculation and cloudy urine afterwards. What has happened to him? This phenomena, so normally when you ejaculate, the ejaculum comes out, you can see it. In this person, the ejaculum is going back into the bladder. This is a retrograde ejaculation, which is one of the common complications of TURP because you can't see where there is damage to internal sphincter. अभी वो तो option में नहीं है ना. If external sphincter is damaged, what will happen? The person will have incontinence because external sphincter is continent sphincter. Corpora of penis does not come in the way. Diathermy overuse can cause some strictures. Bladder neck disruption care. What is injured here in bladder neck? Which is causing it to go back? No, not verumontanum. No. It is internal sphincter. Okay, internal sphincter injury causes retrograde ejaculation. What controls internal sphincter? Which nerves control internal sphincter? Sympathetic, parasympathetic. It is sympathetic. Okay, sympathetic nerves control internal sphincter. Parasympathetic nerves control potency, not internal sphincter. Okay, so if I ask you most common complication of TURP, what is the answer? It is retrograde ejaculation. Injury to external sphincter is avoided by how do you avoid injury to external sphincter? This is the internal sphincter and the bladder neck which got damaged. This is the prostate enlarged. Here is the external sphincter over here. How do you protect it? You keep a limit that you will not dissect below this pit. So there is one pit. Don't go below that because if you go below that, you may end up injuring the external sphincter. So you avoid it by limiting dissection up to verumontanum. That is the landmark. Up to verumontanum. Don't go below verumontanum. And how do you avoid TUR syndrome? And what is TUR syndrome? It happens because of when I'm cutting the prostate, whatever fluid I use, that fluid which I'm using for absorb. And these are all very senior people, so they don't have a good cardiovascular reserve. So if too much fluid gets absorbed, they'll end up with a fluid overload. And sometimes they'll end up with hyponatremia. How is this avoided? Don't use too much fluid. Wherever possible, you use glycine. But see, fluid overload can still happen. So you have to keep a time limit. Don't let the limit be more than 60 to 90 minutes. Okay, so when you start the surgery, you keep a timer that once this limit is reached, I am going to stop. How much ever prostate I removed is fine. Okay, end of the story. I can't keep going and keep irrigating. Person will end up with a fluid overload. Right. VIMP question. VIMP. Similar image was asked in NEET PG, but they had asked a different question. Which of these flaps is used for head and neck cancers? So first and foremost, where do you use latissimus dorsi flap? Latissimus dorsi is the muscle over here, triangle of safety. Remember? Back muscle. It is used for breast reconstruction. It's not used for head and neck. Tram flap is also used for breast reconstruction. So your choice should only be between DP flap and PMMC. Now see the name. Pectoralis major means the flap that I am harvesting should have pec major, which is on the chest. So this flap, which I am harvesting from the chest and putting it on the head and neck for reconstruction, this is PMMC. This is known as the workhorse flap for head and neck surgery. Workhorse flap for head and neck reconstruction. Okay. If they ask you best flap for breast, see, before you asked, I put the slide. Don't worry. The slide is ready. मुझे पता है आप क्या पूछने वाले. Breast reconstruction. You can use synthetic materials, silicone implants, or you can use flaps, which can be pedicle flaps like a tram flap or a LD flap, latissimus dorsi. This photo that you are seeing is this tram flap. You are taking tissue from here with the intact pedicle, taking it from below the abdominal wall to the chest. Pedicle is still there and it is supplying it. So this is your tram flap or pedicle tram. You have free flaps. There is a free tram flap. So tram can be both, or it can be DI, deep inferior epigastric perforator flap, which is the gold standard or the best flap for breast reconstruction. Why it is the gold standard? Why not tram? Why DIP is the best? Because this is a cutaneous flap. There is no muscle. Tram is myocutaneous. So you have to cut some rectus abdominis muscle. So there can be abdominal weakness. Here you are not taking any muscle. It is purely cutaneous. So less risk of abdominal wall problems. That is why it is the gold standard or the best flap for breast reconstruction. Okay. But it's a free flap. So not everybody can do it. Okay. 55-year-old man with gallstone disease inquires about risk factors for developing carcinoma of gallbladder. Which of these is not a risk factor? Choledochal cyst. It is a risk factor for gallbladder also. Gallbladder and bile duct cholangiocarcinoma. Polyp more than 1.5 centimeters. This is risk factor more than 1 centimeter. Age more than 50 years. These are all risk factors. In these cases, you need to remove it. Phrygian cap is not a risk factor. Okay, Phrygian cap is this. It is a normal variant. Nothing happens in Phrygian cap. Okay, it's a normal variant of the gallbladder. It is just having this shape, which is coming from that cap from which the name has come. Have a good look at this table. Risk factors for cholangiocarcinoma. Okay, INICET last year. So, one simple logic for any cancer, anything that will cause a chronic irritation will cause cancer. So, chronic irritation of bile duct because of primary sclerosing cholangitis, worms, hepatitis C, other worms, choledochal cyst, Caroli's disease. ये तो याद है. In the exam, they had given Hep B. Now, see, Hep B also increases the risk. But in that question, the best answer was hepatitis B. Because the others were clear-cut risk factors. So it's not that Hep B doesn't increase, but from the options given, Hep B was the best answer. This is a PYQ from INICET. Okay, I hope you got this. 50-year-old man brought after experiencing a head injury while playing cricket. He lost consciousness but regained awareness within minutes. His GCS is 15/15. CT scan is shown. CT scan, PDH, E for Italy, or SDH, S for banana. Okay, if it's normal, then why does not diffuse axonal injury? Why it is not diffuse external injury? So patient was unconscious. Then he regained consciousness. Currently he is fine. Okay. So it could be EDH because he could be in lucid interval. But I don't see any idli. Idli to nahi hai. It's not EDH. Where is the EDH? Could be concussion, could be diffuse axonal injury because in both CT is normal, but in diffuse axonal injury, GCS is low. There is no improvement after injury. High velocity trauma, not while playing cricket. No, but the trauma should not be cricket trauma. Trauma should be road traffic accident. So if the GCS was 5 by 15, 6 by 15, and he had no improvement in consciousness, then it would have been diffuse axonal injury. So the answer here is concussion. Because he improved immediately. So it's either concussion or lucid interval. Right? So it's not always going to be EDH. That's what I'm trying to say. It's not always EDH. Okay. Right. Identify what is depicted in the X-ray. Artery supply of tram. Tram is two, na? There is pedicle tram, free tram. Pedicle is superior. Free tram is both superior and inferior. दोनों में होती है. What is depicted here? Is it a ureteric stent? Axial flap is a flap where the blood supply is known. So all deep flaps, myocutaneous, osteomyocutaneous, they are all having a known blood supply. So those are axial flaps. Cutaneous flaps where you don't know the blood supply, very superficial local flaps. Those are random flaps where the blood supply is not known. But you don't need honestly to know this. So what is shown here? This thing. Is it an intravenous urogram? No. I don't see kidney. Kidney नहीं दिख रही है. Bladder में contrast नहीं है. So it's not intravenous urogram. It's not retrograde pyelogram. I don't see any pelvic elevation system. दोनों भी नहीं है. Contrast तो कहीं नहीं है. Biliary or ureteric? Biliary or ureteric? It's not T-tube. It's a stent. In T-tube, the tube comes like this. Why biliary? Why not ureteric? I taught this to you, by the way. No, not necessarily double J. Biliary stent भी double J हो सकती है. This is ureteric stent. It should be, one end should be in the bladder. Okay. See, this I don't know na whether it's in the liver or in the kidney. इतना नहीं समझ में आता X-ray में. But lower end तो समझ में आता है ना that lower end is in the bladder. Oh yes. And this is intravenous urogram. Where you are seeing both the pelvic elevation systems and the bladder. Right. So this is intravenous urogram. Right. Okay. GCS question you will 100% get. Identify the mismatched component. Eye opening on painful stimulus is E2 is correct. V3 is confused. No, confused is V4. First, you are oriented. Hi, how are you today? I am fine, sir. Thank you. Digitalis is happy. Then I ask him, hi, how are you today? Sir, I don't know. I'm not feeling too good. He is V4. Then I asked him, Digitalis, how was the class? How was ortho class? What the hell are you saying? That is V3, inappropriate. How was ortho class? V2. Okay. M5 localizing pain is correct. Withdrawing to pain is M4. MNT, non-testable paralyzed patient is correct. Yeah. Level of biliary stent, upper end will be higher or same as ureteric. See, where the liver lies, liver ke piche only is somewhere the kidney, right? So on X-ray you can't make out. Any way of X-ray of making out whether it's in the liver or in the pelvis, renal pelvis? Any way of knowing on X-ray that the upper end of the stent is in the kidney or in the bile duct? Yeah, Rajat, excellent. You take a lateral view. Excellent. Take lateral view. Biliary stent will be little anterior. Huh? Not path-breakingly anterior. It will be slightly anterior. That's why these are not the ways to diagnose. That's why look at the lower end. Much easier. What is incorrect about the swelling shown? This poor boy with this biotic looking thing. This is a cystic hygroma. It may lead to obstructed labor is correct. It is a lymphatic sequestration cyst is correct. It is managed by excision is correct. It does not arise from sublingual salivary gland. What swelling arises from sublingual salivary gland in the head and neck? That is ranule. Okay, that is ranule, which is a mucus extravasation cyst. Okay, it is a mucus extravasation cyst. It lies in the floor of the mouth. It may plunge into the neck, and this is treated by excision plus removal of sublingual gland. Okay, so that is the difference in the treatment. The gland also needs to be removed on the affected side. Right. Which of these is incorrect about primary survey in trauma? Cervical immobilization is performed prior to airway securing. Is this correct? First you immobilize the C-spine, then you do endotracheal intubation. Disability assessment involves checking for fractures. I think I leaked this question, if I'm not mistaken. I leaked it. Okay. Checking for fractures is E for exposure. Okay, it is not D for disability. Disability is GCS. E-fast can diagnose pneumothorax is correct. E-fast can't diagnose retroperitoneal hemorrhage. Pelvic X-ray can be done. It is an adjunct. Okay, it is an adjunct to primary survey. Fine. So disability is GCS. Disability is not fractures. Okay. Which of these is incorrect about polycystic kidney disease? Initial presentation is hypertension is correct. Because as the parenchyma will start getting destroyed, the RAS will get activated, he'll get renal hypertension. It is diagnosed on imaging is correct. What criteria is used to diagnose polycystic kidney? Very nice. It is called Ramin criteria. There is a Ravi here. He only gave the answer. It is Ramin or Ramin criteria. Bilateral renal masses can be palpable. Cysts in lung are not seen. Cysts are seen in liver and pancreas. Okay, not lungs. You won't see lungs anywhere but lungs. Okay. 40-year-old woman for a follow-up consultation after total thyroidectomy. Histology is shown. Surgeon has discussed next step. Which of the following is most likely true? Is this a papillary thyroid cancer? PTC? It's not PTC, no. No Orphanani nuclei. No Samoma body. This is follicular thyroid cancer. Because you are seeing these follicles, tumor cells, capsular invading, vascular invasion. Okay, so they are invading capsular, vascular. You did the total thyroidectomy, you got the diagnosis. What is most likely correct? Spread to bones is correct. FNAC is diagnostic, no. You have to do a frozen section. Tumor shows Samoma bodies, that is papillary thyroid cancer. Tumor has good prognosis. Can a follicular thyroid cancer have a bad prognosis? Is it possible to have poor prognosis in follicular thyroid cancer? Is it possible? Not if there is mets to bone, no. Mets to bone is also not bad prognosis. It will have poor prognosis if it is the Hurthel cell variant. Because that has both lymph node and hematogenous mets, that can have a bad prognosis. Samoma body is seen in papillary thyroid cancer. Okay, medullary thyroid cancer, you see amyloid stroma. Okay, woman presents with swelling in her left leg, which has worsened. There is non-pitting edema. There are no varicosities. What is the most likely etiology? ये सही करके गलत किया. Ravine is the criteria for diagnosing polycystic kidney disease. Like you can't say, na, I have 3 cysts in 1 kidney. Is it PCOD? Sorry, PCKD. So there are criteria based on the age. कि इतनी उम्र के बाद इतने cyst होने चाहिए. Only then you will call it polycystic kidney disease. It's an ultrasonographic criteria. So what is the person having here? He is having elephantiasis or lymphedema. Okay, elephantiasis or lymphedema. I have not asked you the diagnosis, I have asked you what is the most likely etiology. It is filariasis. Okay, but see, this is also a cause of congenital lymphatic hypoplasia. It is given a name. It is called as Milroy disease. होता है ये Milroy disease. That is congenital lymphedema. Congenital lymphedema. ऐसी भी बीमारी होती है, but it is seen usually in the first year of life. Varicose veins can cause lymphedema, and iliopharyngeal block dissection can also cause lymphedema. When do you do this? Iliopharyngeal block dissection. Where have you heard this? It is a treatment for CA penis. Okay, in CA penis, you do iliopharyngeal block dissection. So, you should know the stages of lymphedema. In stage 1, there is pitting edema. Can it be called Stewart-Reeves? No. That is if there is a lymphangiosarcoma. In stage 2, there is non-pitting edema. And the skin can't be pinched. What is that called? Skin can't be pinched. Very nice. That is called as stemmer sign. Okay, that is called as stemmer sign. And in stage 3, you get the skin changes. Any surgery you know for lymphedema? Any surgery you know? You can do lymphatic reconstruction. That is ideal. Lymphatic reconstruction. But many times it's not possible. You can't reconstruct. The filariasis already destroyed the lymphatics. So in that case, you do lymph reductive surgeries. And they are ekdam bhayanak surgeries, where you cut out the skin and the subcutaneous tissue. So you do limb reductive surgeries. If they are done, if you can't do any reconstruction, like there are some names, Thompson, Childs, सब ब्रिटिश नेम है. Hopefully आगे चल के आप लोग भी कोई lymphedema surgery बता दो. Yeah, kind of like you kind of surgically deglove it. Investigation of choice for lymphedema. Yes, lymphangiogram, but it's rarely ever done because it's a clinical diagnosis. So you don't ever have to really do unless you're planning a reconstruction. Congenital usually is bilateral. ठीक है, मेरे नाम से मत रखना और एस्ट्रल कोडेक्स भी मत रखना, अपना नाम रखना. ठीक है, astral codex. So, patient comes with severe abdominal pain after alcohol binge. He is in distress. What is this finding? This is Gray Turner sign for hemorrhagic pancreatitis. Which diagnostic test is to be done for confirmation? Diagnostic test is not CT scan, it is serum lipase. Okay. एक तो there is no CT, I have no angiogram done here. You can do CT scan, CECT, but it is not for diagnosis. It is done for CT is done for what? It's very good. It is done for severity. Okay, you get that CT severity index, which you do after 72 hours of symptoms. So CT is not for diagnosis unless you have a doubt. The diagnosis is on serum lipase. This is a PYQ. This is the one of the few direct PYQs that I put. This was asked in INI-CET last year. And I thought आप लोग भूल जाओगे, इसलिए मैंने डाल दिया. So there are all these fancy things in this to stitch some guide wires, but your focus should be on this. You can see there is a tube and there is this something here. What is that? Yes, I told you to see bolster. So this is a PEG tube or a PEG tube kit. Okay, this is a PEG tube kit. It goes like this and it should have a bolster to keep it in the stomach so that it doesn't slip out. This is your triple lumen cannula for giving IV fluids, TPN, and this is your NG tube, nasojejunal tube, because this has a guide wire. ठीक है, तो ये इमेज तो आपको इजीली आइडेंटिफाई करने आनी चाहिए. This is an important question. You will get these kind of questions. Patient with GERD is being evaluated he has persistent symptoms. Which of these is not an indication for performing the test which I have shown? What test is this? What is the test? It's not manometry. No, it's not manometry. It is 24-hour pH study. Okay, it is 24-hour pH study. So normally when I do endoscopy and I see that he has acid reflux, I see erosions, fine, job is done. But if he has a normal endoscope, or he's having unusual symptoms, or you're planning an anti-reflux surgery, you should confirm first by doing a 24-hour pH study. But if he's having good reflux with PPI, relief with PPI, I don't need to do 24-hour pH study. The correct statement here or the incorrect statement here should be poor relief with PPI. So मैंने poor को good कर दिया. That's how I changed the option. It is poor relief with PPI. And I'll tell you from where I got the question. These are the lines from Bailey. Exact line by line. Ambulatory pH recording to justify diagnosis and guide management in patients with atypical symptoms. These are lines from Bailey. जो आप लोग पढ़ते होंगे नहीं पढ़ा ही नहीं होगा नाम सुना होगा आपने बेलीज दिस इज द नेम यू नो बेलीज नॉट बेली एंड लव बेलीज एंड मैंने गलती से बोल दिया बेलीज और आप लोग कितना खुश हो गए थे बुधवार को है ना volume reflux is an indication for anti-reflux surgery. So if you are sure you're doing anti-reflux surgery, then you will do 24-hour pH. So atypical symptoms, persistent symptoms despite PPI, patient planned for surgery in these cases. In a patient with renal stone, the following crystal was found. What crystal are these? Why not normal endoscopy? In normal endoscopy, you want to get some more evidence na, that is it really normal or is he having reflux? But endoscopy was just by chance normal. These are coffin lid crystals, which are telling you the person is having triple phosphate stones. Okay, these are triple phosphate stones. They are not formed in sterile urine. They are formed in infected urine, typically Proteus infection. Okay, typically Proteus infection. Their radiopaque is correct because they contain calcium, magnesium. They may attain the shape of pelvic alveolar system. What is this? That means they have attained the staghorn shape. Very good. They have become staghorn. And of course, they are amenable to PCNL. All stones are amenable to PCNL. For every stone, you can do PCNL. PCNL is like the be-all, end-all treatment of renal stones. Where nothing will work, you can do PCNL. Yes, King, correct. Patient was brought to the emergency. He had abdominal wall rigidity. Laparotomy was done and this was found. What is this? Tell the correct finding. Perforation, where? In his brain. Peptic ulcer bleed. उसमें rigidity क्यों होगी? TV perforation. Duodenum. Small bowel. यही होता है exam. That we are not able to identify where it is. If this is duodenum, can you hold the duodenum in your hand like this? हाथ में आता है duodenum. And if it is duodenum, then the answer should be omental patch. Then the answer should be omental patch. Please understand, duodenum is not like this in your hand. It is just distal to the pylorus and it is fixed. So a DU perf will be here. Proximally, you will be able to see the stomach. This part of the intestine, if you can't identify, then see this. What is this? What is that? That thing there. That is the mesentery. Thank you. Mesentery means it is small bowel. Mesentery, and the bowel is not showing any tinea coli, so it's not colonic perforation. Even if it was colonic, it doesn't matter. Small perforations, you do simple repair. Omental patch is for DU perforation. Resection and anastomosis is done for large perforations, which you can't just suture. Large perforation. Now, there is no value of small and larger. It's arbitrary. So you have to gauge. Appendix perforation, the appendix will be there, inflamed, and the tip will be burst. That will be tip. Where do you use purse string suture? Anywhere in surgery? Please again the identification. If you see mesentery, the yellow thing is the mesentery going to the GI organ, that is small bowel, right? Purse string suture. It is used for suturing the stump of the appendix, or it is used for suturing anal wiring. Thiersch's anal wiring. There you take purse string suture for rectal prolapse. Thiersch stitch. That is a circumferential stitch. Okay, this is DU perforation. Have a look how he is doing Graham's closure. The stomach is here. Just distal to it is going to be the perforation. Duodenum is not mobile. It can't be brought in your hand like this. Okay. 4-week-old child was brought to the emergency. He was dehydrated. This surgery is done. What is the surgery? What surgery is this? Very nice. This is Ramstad's pyloromyotomy, which you can see now. Pylorus muscle layer cut, mucosa is intact. So the disease is pyloric stenosis infantile. What will the child have? Hypokalemia, hypochloremia, metabolic alkalosis. Hypo. Any doubt? Hypokalemia is the answer. Okay, in surgery, if you don't understand what is happening, hypokalemia. And anytime in your life, surgery or medicine, they ask you IV fluid for hypokalemia. Answer is going to be KCl. Plus whatever IV fluid you are giving. KCl plus Cristalid. Okay, here you give DNS because it's a child. But anytime in your life, it will be KCl plus Cristalid for any hypokalemia or oral KCl. If the patient can tolerate oral KCl. Okay. Right. Answer this. This is a repeat question. Similar question came in NEET last year. Similar question. मैंने थोड़ा उसमें trick डाल दिया. After gastrectomy and gastrojejunal anastomosis, what surgery is done here? Gastrectomy and GJ. What is the name of the surgery? For one of the likely surgeries, it could be Billroth 2. Could be. If it is only distal gastrectomy and GJ, it could be Billroth 2. Could be. He is likely to suffer from all except iron deficiency anemia is correct because there will be reduced gastric acid. Acid is required for iron absorption. Post-meal hypoglycemia is correct. That is called as dumping, which I will tell you. B12 deficiency is possible because reduced intrinsic factor. Gas bloat syndrome is seen after Nissen. Okay, it is seen after Nissen. That's what I did. I changed this part. I gave you the complication of some other surgery, very in that close area. And I was like, if you have mugged up the complications, then you will remember, yes, gas bloat is a complication. I have heard it. And you will be like, nahi, wo to hai. है ना, वो तो है. Yeah, iron deficiency anemia also because duodenum is bypassed, correct? So, few things on dumping, very few things. It is going to be seen after gastric surgery, like a gastrojejunostomy, due to rapid transit. The whatever you eat has a rapid transit. It gets dumped into jejunum. So whatever you eat, normally it stays in the stomach for some time, right? If I do a gastrojejunostomy, so what will happen? The food will quickly go into the jejunum. Whatever you eat, it gets dumped into the jejunum. Now, jejunum has a lot of absorptive power. So after certain foods, you can get what is called as early dump. Typically after foods which have like a lot of sugar or liquid sugars. Best example, liquid sugars. Like a milkshake. I always say Coca-Cola, milkshake, even alcohol. So what happens here is when I have those hyperosmolar foods, they go in the jejunum, they pull the blood, the plasma into the jejunum because of their osmolarity. So the plasma volume reduces and the jejunum gets dilated. Jejunum will bloat with the plasma fluid. So what the person gets, it happens almost immediately. He gets a hypotension. So whatever symptoms he gets are because of hypotension. Epigastric fullness, sweating, lightheadedness, diarrhea because of the dumping. So the treatment here, lie down. Okay, he just has to lie down, elevate his legs, BP will improve, the symptoms will go away. But sometimes with the same foods, he gets late dumping, which happens 1 to 3 hours after meals. This happens because if the food has too much sugar, the food can get quickly absorbed. You will get a sugar spike. The spike will cause too much of an insulin response, and that will cause a hypoglycemia. So here the person is having a hypoglycemia. So late dumping, hypoglycemia. And it's happening with the same kind of food but much later. So very easy to diagnose. 1 hour after food, he starts getting tremors, palpitations, similar symptoms. You check the sugar, sugar will be 45, 50, hypo range. You know it is a late. Okay. Management for both, avoid the precipitating factors. Whatever was the trigger has to be avoided. Then he will not get done. Okay, cool, fine. We'll just do this, then I'll give you small break. Okay, we'll do this, then I'll give you chota break. What is a mismatch finding in peripheral vascular occlusive disease? Burgess disease affects crural vessels. What are crural vessels? Crural माने क्या? Crural क्या होती है? ये वर्ड कहाँ से आया है? क्रूरा, क्रूरल, ऐसी तुक्का. Burgess disease affects distal vessels in the lower limb. It is seen in young smokers. But what does the word crura mean? Crura like curare like drug? No. Crura are the crurae of the calf muscles, which means the blood vessels are within the calf muscles, which means they are small vessels, like anterior tibial artery, posterior tibial artery. Those are crural vessels which are affected in Burgess. Okay, कोई मैंने अपने मन से वर्ड नहीं डाला. What about upper limb? Distal upper limb. Burgess normally affects lower limb, not upper limb, normally. Aortoiliac block, Lerich's syndrome is correct. Aortic bruit can be heard. Superficial femoral artery block, calf claudication is correct. Rest pain relieved by leg elevation. Why is this wrong? It's not relieved by leg elevation. Walking से तो बढ़ती है, अरे तो रेस्ट पेन है. Walk हो ना हो, cannot be relieved. No, 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 no. It can be relieved. कुछ भी. It's not relieved by leg elevation. It is relieved by what? What will relieve rest pain? No, walking से कैसे relieve होगा? It is by hanging the legs down. Okay, he hangs the legs by the side of the bed. He can't sleep at night straight because if he sleeps straight, the blood supply is less. So when he dangles the legs by the side of the bed, the blood supply improves a little bit. Little. The rest pain reduces. आई बात समझ में? Okay, cool. So sites of obstruction and findings are these. Please be back not later than 7:15. Then we'll proceed with the rest of the questions. Otherwise, let's move on. We are halfway done, almost. So let's do the second half of the questions. Okay. This is one of my favorite topics, which I always feel will feature some way or the other in the exam. So during a mass casualty incident, color-coded tags were used. Which of the following tags is incorrectly matched? So what are these tags which are incorrectly matched? Red means immediate, what can kill the person immediately. EDH is correct. Yellow, hollow visceral perforation. Is this right or wrong? This is correct. So hollow viscous perforation is not immediate. It's not immediate. It is urgent, or it is yellow. Green is not open fracture. Green is simple fracture or a closed fracture. 90% burns, bad craniofacial trauma, open chest traumas, injuries with which the person will not survive are going to be black. So this is the triage coding. This is another picture from Bailey, not Bailey's. Okay, everything is there. So whatever question you are asking, answer is in this page. Compound fracture. Unless it is severely bleeding, any profuse external bleeding is going to be red. But a compound fracture per se is going to be yellow. Unless it's profusely bleeding. But so all your categories are here. Yellow is the category which will confuse you because they all look dangerous, ruptured viscera, pelvic fracture. You will think it should be red, but it is not. Okay. But any active massive bleeding is going to be red. Anything that will kill you immediately will be red. So be a little flexible in this. Which of these is not a complication of TPN? So tension pneumothorax can happen during line insertion. So it is a line complication. What is this metabolic bone disease? All compound fractures. यार अनुष्का ऑर्थोपेडिक होने के बाद तुम ऐसे नहीं बोल सकते. Compound fractures of long bones with vascular injury will bleed. Not every compound fracture. ऐसे नहीं बोल सकते यार. So this is a line complication. See, I don't teach ortho, but like medicine, I know a little bit of ortho. So you can't. I know Costello Anderson. Okay. What is this metabolic bone disease? See, Bailey में नहीं है blue category. So unless you've been taught it in PSM or somewhere else, then you can use it. But according to Bailey or ATLS, उसमें तो नहीं है. हाँ. Metabolic bone disease क्या है? Is it related to? It simply means vitamin D, calcium deficiencies, osteopenia, osteoporosis. Right? Liver dysfunction कैसे होगा? TPN से. It causes cholestasis or cholestatic jaundice. Okay, cholestatic jaundice. Diarrhea is not seen. Obviously, diarrhea is a complication of tube feeds, like nasojejunal feeds. वहां से मैंने ये चुराया diarrhea. Okay, that is tube feeds. Overfeeding intravenously will still not cause diarrhea. How much ever you overfeed, फिर भी diarrhea नहीं होगा. Okay, let not our imagination run so wide. No fiber, it's not going in the gut. How will it cause diarrhea? At least not directly. Directly तो नहीं cause करेगा. Cholestatic jaundice happens because of the fat in the TPN that causes cholestasis. Metabolic is should be underfeeding. Vitamin D deficiency. So these are the complications. यहाँ से लिया मैंने. Metabolic bone disease, liver dysfunction, vitamin deficiency. It's from this table from Bailey. Straightforward. Such an easy question. Okay, this is a PYQ. Patient has undergone cholecystectomy. MRCP shows leak of bile from the right posterior duct. What is the Strasbourg grade? If the leak is present, means the duct is cut. C for cut. If the right posterior duct was blocked, it would be B. B is blocked. Blocked right posterior duct. A is cystic duct leak, which is the most common type. And D is common hepatic duct leak. So these are the Strasbourg A, B, C, D. Confusion is always between B and C. Yeah, no, all leak except D. Cystic duct leak. All of them will leak except type B. B is the only one where it doesn't leak. So A में cystic duct is leaking, B is blocked, right posterior, C is right posterior leak, D is common hepatic leak. ठीक है? Why not A here? A where? No, right posterior duct leak is not A. No? A is cystic duct leak. I'm sure even in this question you must have overthought or underthought. You must have done some gadbad because I asked a question on radical neck dissection. Most of you will think modified radical neck dissection. मन में तो वही आता है ना, MRND is what everybody thinks. If you didn't make a mistake in this, that means you are alert. And see, I put this question somewhere in the middle by the time your mind would be fatigued. So you would straight away see which of these is preserved and you would mark spinal accessory nerve. Because you had the mnemonic, spinal accessory nerve, SCM and internal jugular vein. और मैंने उसको लास्ट में छुपा के रखा, फटीग भी आएगा, you would look for it and you will find it somewhere else. You will be like, नहीं ये trap भी नहीं है, it's not the first answer. But unfortunately, it's not MRND, it is RND, where you don't remove level 6 nodes. Sorry. Level 6 is not removed. 1 to 5 are removed. Submandibular gland is removed. Spinal accessory nerve, internal jugular vein are all removed. Okay. Fine. This was an easy question. Yeah, thyroid, papillary thyroid cancer is where you remove level 6, central compartment clearance. Correct. That's right. Mismatched hernia types and location. This was easy. Femoral hernia below inguinal ligament is correct. Deep inguinal hernia medial to inferior epigastric is correct. That is called Hasselbeck. Hasselbeck triangle. Indirect inguinal defect in fascia transversalis, that is the deeping. Bogdalic is not right posterior, it is left posterior. Okay. Bogdalic is left posterior, which is the most common type. So most common type, Bogdalic. That is left posterior. And right anterior or just anterior is going to be Morgagni, this one, which is quite rare. Okay. Now, what is the problem in this? This happens in utero, that the diaphragm does not close. There is a defect in the diaphragm. So what happens in utero? The intestines go into the thorax. So in utero, the lung does not develop. So when the child is born, he has a pulmonary underdevelopment, hypoplasia. So the presentation at birth is hypoxia. He'll have all findings of hypoxia, cyanosis, gruntal breathing, all those findings. And when you are going to investigate, he may have findings of pulmonary hypertension, which is a marker of poor prognosis. And of course, there will be, when you will auscultate, you will hear bowel sounds in chest. Usually on the left side, scaphoid abdomen, because the bowel has gone in the chest with scaphoid abdomen. So you will investigate, you will do X-ray, you will put Ryle's tube, all those things. When you decide the treatment, PYQ, what will you not do? Bag and mask ventilation. So what will you do first? Endotracheal intubation. Since he's having hypoxia, stabilize, confirm the diagnosis, and then do a repair. And the repair you are going to do usually from the abdomen side. Because diaphragm is in between, now you can go from the chest, you can go from the abdomen. You will repair from the abdomen. And the surgery is not done after birth. It is done after few days. Okay, it is done after few days. Usually it is going to be transverse colon that will herniate. Usually, because that is the most mobile part. Thoracotomy should not be required if you can treat the hernia from abdomen. So thoracotomy should not be required. Usually it's not going to be. Okay. Feeding through NJ tube, yeah, if he is able to tolerate the feeds, then yes. If he is able to tolerate the feeds. Hernia mesh or suture depends on the defect. So small defect, you can just suture. Big defect, you have to put a mesh. What is this? What ulcer is this? Question skipped. Oh, sorry. Sorry, वो आगे पीछे में चला गया. We'll come back to that. Sorry. So patient underwent surgery for rectal prolapse. What is this procedure? You are saying you are taking these, they are like purse string, but actually they are plicating stitches. So this is Delorme's plication. Okay, it's one of the perianal procedures. ये मैंने leak करा था, हाँ. So this is one of the perianal procedures for repair of rectal prolapse. Wells is abdomen. You put a mesh. Thiersch is anal wiring. Altemeyer is perianal resection. Okay, which is done usually for strangulated prolapse. So Well and Ripstein are abdominal mesh procedures. Okay, which are preferred in younger patients. What is this thing over here? You are calling it a venous ulcer. Why? What tells you it is venous ulcer? There is nothing in it that tells you venous ulcer. One is this is medial malleolus, it is above Gator's area. Anything else that tells you it's a venous ulcer? Answer is venous insufficiency. Shallow nahi re, don't say shallow. You see the black thing around. You see this black? That is a pigmentation. You see some ankle flare. These are chote reticular veins. So all these things tell you it is a varicose vein with a venous ulcer. Yeah, C stage. C stage C6, huh? It is C6. Don't say I see eczema, it is C4A. Okay, remember you are MBBS pass. You are not a 12th pass. Okay, you are MBBS, you are not 12th pass. It's active ulcer. What ulcer is this? Deep ulcer, weight bearing area, callosity, trophic ulcer. Next image. What ulcer is this? Or whatever you can make from this. You can see these are some burns, wound scars. The skin has gone little inside. There is some contracture. So an ulcer like this in a burn scar or a chronic ulcer, that is a Marjolin ulcer. What is Marjolin ulcer? In simple words, it is a squamous cell carcinoma. That's why it is having all these raised edges. Edges are so much higher. That is a Marjolin ulcer. Never asked. Okay, this image has never been asked. This is the only good image available on the internet. Okay, this is the only good image on the internet. What will you do next? Patient comes with this wound. What will you do next? It can occur on deep burns usually. So second degree deep or full thickness. What will you do next? Don't say resection. You are going to take a biopsy from the border. You have to confirm the diagnosis. So to confirm, take a biopsy. Don't do excision. It's a squamous cell carcinoma. You will do a biopsy from the border, edge or a wedge biopsy. Okay, and then you will decide what to do. What is the management of the condition in the below neonate? What is the condition? Why bladder extrophy? In Marjolin scar, within the scar won't have lymphatic spread? Usually no, because the lymphatics also get destroyed by the primary pathology. Usually. No, you can't tell me this is bladder. Come on. What guesswork is that? That's not bladder. I mean, you can't guess like that. This is the umbilical tube or the umbilical cord. So whatever is coming out is infraumbilical. So it's an infraumbilical abdominal wall defect. That's why it is a ectopia vesica or a bladder extrophy, because it is infraumbilical and you can't see bowel or anything coming. So what is the treatment of all abdominal wall defects? Is you have to close the abdominal wall repair, and many times you have to do bladder repair also, because there are bladder problems also. You have to do a planned abdominal wall repair. Okay. Someone was asking me one question on Telegram. I just happened to check it in the little break. What abnormality is seen in ectopia vesica? So normally your urethra goes like this. It is very close to the lower surface of the penis. It goes like this. then it goes like this and opens here. Okay, this is your normal urethra. Sometimes boys get a urethra which opens here. That is called hypospadiasis. Okay, sometimes the urethra instead goes and opens on the superior surface, epispadiasis. In your opinion, what is more common, hypo or epi? Overall, hypo is much more common. Overall, hypospadiasis is much more common. It is seen in 1 in 250 boys. So today there are about 500 of you. So let's assume 50 girls, 50 boys. So at least one of you boys must be having a hypospadiasis. You can check 100%. As per the statistics, one of you will be having it. Okay, so it's very common because the urethra is on the lower surface instead of going till the tip. If it opens in the lower surface, hypospadiasis. But in this condition, you normally get, if it's a male child, you get epispadiasis. But epispadiasis as such is very rare. Okay, it's not very common. है किसी को बता देना. Anchit is very curious to know. I wonder why, but he is curious. तो आप बता देना भाई. So it is seen in 1 in 250 boys. And someone asked me, sir, how do you correct it? And when do you correct it? How do you correct it and when? So you are going to correct it before the child starts urinating by himself. That means before the child learns toilet training. So you have to correct it before 18 months of age. Now in hypospadiasis, there are 2-3 problems. One is the hypospadiasis. The other problem is because the distal part of the urethra is missing. This part is missing. Na? So the problem that happens is there is a little cord in that area, a fibrous cord, which pulls the penis or the glands towards the hypospadiasis. So many times in hypospadiasis, you have what is called as associated curvature of the penis. That is called as a chordae of the penis. The penis is bent. So when you have to fix it, you have to do 2 things. One is you have to take the urethra terminally. Second is you have to correct the chordae. What will you correct first, chordae or urethra? And use your dimag. First you want to take the urethra to the tip, then correct the chordae, or first you want to correct the chordae, then take the urethra to the tip. So common sense should tell you, first correct the chordae, because then you know what is the length of the penis. It's bent like this. First make it straight, then take the urethra to the tip. That was the question of INICET. That's exactly what they wanted to know. You're thinking that will I make it straight first, or will I take the urethra, or already it is curved, into a curved penis, then make the penis straight? वो straightening में the urethra will again tear. It's possible ना. Curved urethra आपने terminal कर दिया और फिर penis को straight कर दिया. Disaster. That's what they wanted. So the order of correction is first correct the chordae. Then once you have corrected the chordae, then take the urethra distally. That is called as meatal advancement or urethral advancement. I won't say meatal advancement. You do a urethral advancement, means reconstruct the urethra. How do you advance the urethra? There is a gap there, na? How do you fill the gap? You do a urethral reconstruction. How do you fill? Means there is a missing segment. Yeah, no, not buccal mucosa. Buccal mucosa. Buccal mucosa is used for normal urethral reconstruction. Here you don't use it. Here you use foreskin, which is why circumcision is contraindicated in hypospadiasis. You use foreskin. Once you have done the urethral length, एक बार आपको मिल गई, then you do a meatal opening or meatoplasty. Okay, that is the answer. Fine. So overall, in urethral problems, it is hypospadiasis. Epispadiasis is only in ectopia. ठीक है? आई बात समझ में? ये लॉजिक समझ गए ना, तो ये आंसर रटना नहीं पड़ेगा, वरना रटोगे और then you are just remembering CUM, whatever that means, or CUML, and then you'll say in this app this is given, but on your app this is given, and that, and this and that. And इसका कोई reference भी नहीं मिलता कोई book में for me to throw in your face that this is what you said, but this is what the standard book. There can be Cordian epispadiasis also, can be there, yes. In both urethral problems, the distal length can give you a Cordy. You are all relating to it so much. It's like you are the culprits, and now you're just feeling happy about it. बोलने वाले आप लोग ही तो. Female presented with pain and redness. She is lactating. Temperature is raised. Cracked nipple is dotted. There is a liquid collection of about 20 cc. Means she has a breast abscess. What will you do? You will do USG guided needle aspiration. When do you do suction catheter insertion? It is done for large collections. Large means more than 30 cc or more than 3 centimeters. You can do IND, but preferred treatment will be suction catheter drainage. Okay, this is the line from Bailey. Again, Bailey, 20th edition. Any pus seen on ultrasonography should be aspirated and sent for culture and sensitivity. Contrary to the practice of IND, ultrasound guided drainage gives excellent cosmetic results in abscesses more than 3 centimeters. A vacuum suction catheter drainage is inserted to drain the pus. Okay, directly from Bailey. Antibiotics are assumed that you will give. Assumed. Okay, means it need not be spoken about. It's the unspoken rule. So answer here is going to be USG guided needle aspiration since it is less than 30 cc. Okay, Ravi? Fine. This is the proof. Identify the pathology and the next step. So what you're seeing here, last time they asked you varices. This time they will ask you Barrett's. So they are telling you this is the GE junction. And what you are seeing, the red stomach mucosa is coming up onto the esophagus. So these are your tongue-like projections at GE junction. It's not varices. It's not candida. Candida is curdy white. It's not red. It is curdy white. So this is Barrett's, multiple biopsies as per Seattle biopsy protocol. What you are seeing here, this is another image. You must know. Okay, must know image. You are seeing these linear erosions in a certain order. This is called as watermelon appearance, which is seen in GAVE. GAVE is gastric antral vascular ectasia. On endoscopy, can you tell me what part of the stomach is showing those linear erosions, which are looking like watermelon? You know why it is antrum? Don't say because GAVE is in the antrum. Because you can see this hole over here. That is a pyloric opening. This is just proximal to the pyloric opening. So this is the antrum. Okay. From an image, that is the best thing you can make. Okay. Usse zyada you can't make out on an endoscopic image. Right. So this condition, it's a benign condition. It will normally not cause any problem. If it causes any problem, you can do a coagulation, endoscopic coagulation. Ectasia means dilated vessels. So these are small arterioles which are dilated. There is no reason why they dilate. Sometimes they cause bleeding, but normally they are found incidentally. If they cause bleeding, you can coagulate them endoscope. I am sure some of you would have made a blunder in this. I am sure. Which of the following suture material is monofilament and non-filament? मैंने आपको 4 ही suture material बताए थे. आप लोग yes sir बोल रहे हो मतलब ब्लंडर किया है. Oh damn. Polygalactin, vicryl, polyfilament. braided, absorbable. Okay, it can't be used forever. It is workhorse suture material, but it is absorbable. PDS, monofilament, absorbable, used for bilioenteric anastomosis. Remember, bilioenteric anastomosis, urinary surgeries, because it is absorbable. No infections, because it is monofilament. Polypropylene, your favorite proline, it is monofilament. It will remain forever, non-absorbable. That's why it is used ना for mesh. इसलिए तो mesh में use होती है, non-absorbable है. Mersilk, polyfilament plus non-absorbable. ये 4-5 आने चाहिए. ये मैंने उस दिन क्लास में भी बताया था. या black suture. Nowadays Mersilk barely used. Drain fixation, छोटी मोटी चीजों में use करते हैं. Otherwise, not very commonly used Mersilk. Laparoscopic surgery में nobody uses Mersilk. Everybody uses PDS and polypropylene. Most of the time. So those two you should know. Did you get this? What is the material used for fixing the mesh? So you are seeing this mesh. You are seeing the intestines here. This colon, see, this is how colon looks, huh? Exactly like this. This is colon, and what you are seeing, this white band, is the tinea coli. This is your small bowel. So it's intraperitoneal. Mesh is being put on top. Okay, mesh is being put on top. You can see the intestines below. So it is an intraperitoneal mesh. You don't see ostration in this photo, but you can see these appendices. These are the appendages. वो दिख रहे हैं. These hanging fats are appendices. It's not mesentery. Okay, so this image, I'm telling you, you will be asked only two images. Either you will be asked IPOM. IPOM is where the mesh is placed from inside onto the abdominal wall. So below you can see the intestines. Above is the mesh. It is a dual mesh, two surfaces, or composite mesh. Or they will show you open mesh repair, which will be only like an open hernia repair, Liechtenstein repair. That will be only where the mesh is put on top of the defect. If it is above the peritoneum, Anushka, how are you seeing the intraperitoneal organs? How can you see intraperitoneal organs if it is above the peritoneum? If the defect is here and this is the peritoneum, only when I place the mesh intraperitoneally can I see the intestines below. If I place it here, sublay, then नीचे will be the peritoneum, na, not the intraperitoneal organs. Sublay is a very small space. Now ऊपर ज़्यादा है ना नीचे ज़्यादा. नीचे peritoneum है, ऊपर muscle है. In that space, to put the mesh is difficult. And they can ask you image, but I would not expect them to to even find one. Like how will you understand नीचे is peritoneum? कैसे समझेगा? नहीं समझेगा. But if they show you TAPP or TEP, inguinal hernia, that is sublay. But then you can't make that out from the photo. That will be from the history. So open hernia repair will be only. I'm just telling you for exam. It's not in real life. But for exam, open hernia repair, think of only. You can see intestines, IPOM. TAPP, TEP, sublay. ऐसा पकड़ के चलो तो image से समझ में आ जाएगा. Inlay nobody uses. Inlay image ही नहीं है because nobody uses inlay. What is the main purpose of the test in the image? What is this device the person is holding? What device is he holding? This is a gamma camera. Some breast surgery is happening. He's using a gamma camera. He's doing a small incision. It's not a very big incision. Why it is not MRM? Why it is not MRM? So answer here is to find the first draining node. Why not MRM? So first is an MRM. There is no sentinel lymph node biopsy. Okay. In MRM, you will straight away remove. Okay, straight away. There is no SLNB. Straight away you do axillary clearance, irrespective. Anything else that tells you it is not MRM in the photo? Something in the photo that tells you it's not MRM. See, in MRM, the incision has to include the nipple areola complex because you have to remove full breast. ये incision में full breast में nipple तो आ ही नहीं रही है, ये तो बच जाएगा. So it's not MRM, it's a wide local incision. Okay, these small things will help you get your answer if you are just aware of what to look for. Okay, little awareness is what you need. Is it correct that extraintestinal? No. In ulcerative colitis, surgery is curative. In Crohn's, surgery is not curative. So in Crohn's, extraintestinal manifestations are dependent on medical management, not on surgery. Surgery does not cure Crohn's. Surgery can only cure ulcerative colitis. So in that, the extraintestinal manifestations go. IPOM is usually laparoscopic. Usually laparoscopic. So patient has this red patch on the buccal mucosa. Red means erythroplakia. Erythroplakia means biopsy. Even if it was leukoplakia, still you would have answered marked biopsy. Yeah? You have to do biopsy. Why? Why are you doing biopsy? Red. No, don't say pre-malignant. वो मुझे पता है. तो biopsy क्यों करना है अगर पता है pre-malignant है? To check for dysplasia. Because if there is dysplasia, I have to remove it. If there is no dysplasia, then you can just do observation, which will not be in erythroplakia, which will be in leukoplakia. Because there, the chances of cancer, he's a younger brother, no, the more benign brother, timid brother. He's not the dada. This is the dada. Dada, you have to do biopsy because dysplasia will be there. He'll be out there corrupting his younger brother, his cousins, everybody, bullying everyone in school, like some of you, bullying everyone here in class. Oh. INI-CET popular topic, indications for surgical exploration and trauma accepting. Penetrating trauma with shock, yes. Okay, penetrating trauma with shock, with evisceration, gunshot penetrating trauma, or peritonitis. Retroperitoneal zone 1 in stable patient. Stable patient also you want to operate? Yes, of course. Because these zones are seen in stable patient only. They are CT zones. So anyways, the patient is stable, but zone 1 you have to always operate. Aortic injury, IVC injury. Traumatic cardiac tamponade with Bextrade in today's day and age is the answer. Surgery. Hemothorax output should be more than 1500 ml blood immediately. Or 250 ml per hour for 3 consecutive hours. Okay. Our favorite topic. Patient comes with abdominal pain. He has multiple calculi in the gallbladder and a dilated CVD. Okay. And a dilated CVD. I am sure in time, immediately, the moment you put the ICD. Why not cardiac tamponade? The treatment for cardiac tamponade in trauma is surgery. It's not thoracocentesis. So I thought you will see this and then you will go for MRCP, dilated CVD MRCP. No, it's not pericardiocentesis. That's not the preferred treatment. But on further imaging, a 5 mm stone is found in the distal CVD. So you know there is a CVD, so answer is ERC. Stone मिल गया. Sakina ने सही word बोल दी. Stone मिल गया. So here I purposely put first dilated CVD because I know you guys use what are called as buzzwords or shortcuts or tricks up, tricks up your sleeve and all those things, mnemonics. But examiner knows you use that. So mnemonic with the M. Heuristics. I don't know what word that is. Heuristic. That's why I first put dilated CVD, then I put on further imaging. Okay, on further imaging, a stone is found. If a stone is found, answer is ERCP, and after ERCP, you will do lap cholecystectomy. Okay, after that, you will do cholecystectomy. Right. Shown below is a popular sign that occurs in acute appendicitis. So what he is doing, he is pulling the hip, means he is hip extending the hip. And the person is getting pain in the right iliac fossa. This is called as psoas sign. Okay. Obturator sign is reverse of psoas. He gets pain on hip flexion and internal rotation. That is the reverse of psoas. Very cute picture, I know. Okay, don't ask me from where I got it. No, it's not Bailey pick. It's not Bailey pick. It's not any app cup. Neither. Okay, it's not any book. It's not any app. Bloomberg sign, rebound tenderness. Rovsing sign, you press in the left, he gets pain in the right. Okay, press in left iliac fossa, he gets pain in right iliac fossa. That is the Rovsing sign. These are all findings of acute appendicitis. Ghibli तो नहीं लग रहा है यार. मतलब you think ये भी Ghibli ने pick up किया. And it's not Ghibli, yeah? It's Ghibli. It's not Ghibli. वो spelling Ghibli है, but it is pronounced as Ghibli. बनाओ इस पे रील आप लोग, अगर आप में वो you do those kind of funny reels. मैंने कोई रील में ही देखा है. Patient presents with painful perineal nodules, now with serious discharge. What is incorrect? So what is the person having? Fistula in ano. Okay, the person is having fistula in ano. I put 2 questions on fistula. Ulcerative colitis, no. Ulcerative colitis, no. It is Crohn's disease. Normally, perineal fistulae multiple are seen in Crohn's. MRI perineum is true. It is believed to originate in the intersphincteric anal glands. It's true. That's how the abscess begins. And lift procedure. Lift stands for ligation of intersphincteric fistula. It is used for intersphincteric or type 1 fistula. Okay, ligation of intersphincteric or type 1 fistula. I hope you got this. If you didn't get this, then it's a slap on my face if you didn't get this. What is the structure visualized in cholecystectomy? This inner structure that I have marked, that is cystic artery. Okay, the bigger outer structure is the cystic duct. Okay, bigger outer one is the cystic duct. CVD should not be exposed usually. Okay, it is not exposed in cholecystectomy. CVD will be somewhere here. Ruvier sulcus you can't see in this photo, but it would have been here approximately. That would have been Ruvier. So this appearance where you are seeing 2 tubes going in the gallbladder, that is your critical view of safety. Okay, critical view of safety. Right? ये इसमें आपको Ruvier sulcus दिखेगा. Very nice. That is Ruvier sulcus. Which of these is incorrect in trauma management? The treatment of tension pneumothorax is ICD placement in 5th intercostal space in mid-axillary line. This is true. Triangle of safety. Kerr sign is seen in splenic trauma. True. What is the other sign that you see in splenic trauma? Balance sign. Okay. Kerr sign, left shoulder pain on pressing in the perisplenic area. Balance sign, left flank dullness. Diaphragmatic rupture is best diagnosed on CT. Why is this wrong? Why it is wrong? Or you got this by exclusion? It is best diagnosed on surgery. Even CT may miss diaphragmatic rupture. CT may be missed. Perineal trauma with blood and meatus means bulbar rupture is correct. Okay, that injury, fall astride injury, manhole cover, perineal hematoma, bulbar rupture, right? This is the line from Bailey. Most diaphragmatic injuries are silent. There is no single standard investigation. CT scan and ultrasound all lack positive value, but negative value. The most accurate evaluation is by video assisted thoracoscopy or laparoscopy. Okay, in trauma we do X-ray. So can it be picked on that? It may be picked on that, but they are not very efficient. Ideally, it should be picked on CT, but according to Bailey, even on CT, it lacks positive or negative predictive value, right? That's why the best answer is going to be surgery. You can do thoracoscopic or laparoscopic or laparotomy. Okay. Patient came with flank pain radiating to groin. On further imaging, this is what is the image? What is the image? Don't tell me the diagnosis, just tell the image. Is it a KUB or a IVU? It's a KUB. You can't see the ureters, you can't see the kidney, can't see bladder. There is no contrast, so it's a plain X-ray. And obviously what you're seeing is this small little stone. Now, I don't know where the stone is in the kidney or ureter. Definitely not in the bladder. So cystoscopic removal to nahi hai, because bladder is in the pelvis. So if I can somehow come to know that it is in the ureter or in the kidney, then I will know what the answer should be. Now see, how to know where it is. This is the sacrum. Okay, this is going to be L5, L4, L3, L2, L1. T12 is में दिख नहीं रहा, but let's say T12 is here, and this is the 12th rib coming out of T12. Let's assume this is T12. Kidney lies somewhere here. T12, L1, L2. Unless it's a horseshoe kidney, it will be T12, L1. That's where the renal angle is. Ureter start from L2, transverse process, L3, L4, L5. So location of ureter is L2, 3, 4, 5 transverse processes approximately. That is the upper and middle ureter. There is a distal ureter also that can't be seen on X-ray, which is going in the sacroiliac joint area. So this is a ureteric stone. Answer is going to be ureteroscopic removal. आया समझ में? So it's a ureter. Anything else that tells you it's a ureteric and not a renal stone? Apart from this fancy location way of calculating. Ureteric can be done till 1 centimeter stones directly. More than 1 centimeter, then you'll have to do lithotripsy followed by ureteroscope. Bladder में नहीं है वो. Those are densities of the bone. If it was kidney, then what will be the best answer? Then it depends on the size which they have not given you. So you would have marked ESWL, look small. है ना? Asking level, what kind of level? So pain in the flanks, radiant to groin, is not seen in renal stones. This is a colicky pain, loin to groin. Again, it tells you it's a ureteric stone without the image. See, you use common sense, you will get the answer. Loin to groin pain radiating is not renal stone. Renal stone is at the renal angle. This is niche se upar se niche. Anything else that tells you it's a ureteric stone? See, so many clues are there. Anything else that tells you it's a ureteric stone? Medial, no, it's not medial. You look at the shape of the stone. The ureter is like this, no? This is how ureters are. They are tubes. If I have a stone in the tube, it will take this kind of a shape. It has to be a little longish. So ureteric stones always have a shape like this. They are called as pip calculi or a seed calculi. They are like seeds in shape, usually because they take the shape of the ureter. That's why it is so many points go in favor of ureteric stones. But what I wanted you to see was how to look for it on the X-ray. That you look at, if this is L5, L4, L3, L2, the ureter will be on the transverse process tips. That is the ureter on each side. Radio opacity is in the ureter. If the pain is only in the flank and it is a continuous dull aching pain, then it could be a renal stone. If it's a continuous dull aching pain. Identify the mismatch finding in breast examination. Infiltration of dermal lymphatics, pude orange is correct. Duct ectasia, slit-line nipple retraction. Say yeah. Yes, it is correct. Hopefully. Infiltration of Cooper's ligaments is dimpling and puckering is correct. Infiltration of veins by tumor is Mondor's is wrong. What is Mondor? It is a idiopathic superficial thrombophlebitis. So the veins of the chest undergo inflammation. They don't know the reason. It could be related to smoking. Smoking is one of the risk factors. It can be seen in men also. Huh? Superficial thrombophlebitis. It can be seen in men. So veins on the chest wall become cord-like. Most common vein in Mondor's is the lateral thoracic vein. Okay, it is the lateral thoracic vein. And this is a clinical diagnosis. Treatment is just reduce the arm movements. If required, give the person NSAIDs for pain. Nothing needs to be done. It will be self-limiting. Okay, so there is no tumor here. So the mismatch finding is answer is C. Dermal and subdermal are same here. Okay, now what is this duct ectasia? It is usually seen in smoker women, where the ducts, because of some reason, undergo like a dilation. So this is the nipple areola. These are the ducts. Some of the ducts become dilated. Ectasia means dilation. So some of the ducts have become grown up. They have become blown up. Because of that, there is stasis of secretions. And eventually, what you are going to see is greenish nipple discharge. Over time, there is going to be inflammation around these ducts. Over time, as the disease progresses, which is called as periductal mastitis. No, this is not engorgement. Engorgement is in lactation. So over time, you'll get a periductal mastitis. And once the mastitis heals and the ducts undergo fibrosis, you get a slit-like nipple retraction. That is because of the fibrosis. So it starts with greenish discharge, inflammation, like abscess. Then you get a slit-like nipple retraction. What is the treatment? You have to excise the entire ductal system by taking a conical incision. That is called as Hadfield procedure. It is a conical excision of the ductal system. INI CT mein, in fact, when it was AIMS, it was not even INI. That time they used to ask. In AIMS, that is called Hadfield procedure. Duct papilloma is a very easy disease to understand. When I say ductal papilloma, so in one of the ducts, there is a tumor. Okay, benign tumor. That is papilloma. Benign. Sometimes the tumor will bleed. So the woman will present, it will be a young woman with bloody discharge. Old woman with bloody discharge, you will think of malignancy. Young woman, you will think of papilloma. You can confirm it by triple assessment. Here, what you need to do is you just need to excise this duct. Okay, that is called as microdocectomy. Okay, the incision that you take is a tennis racket incision. Okay, it is a tennis racket incision. Why bloody? Because papilloma will bleed. That's why bloody. Papilloma is a benign tumor, but sometimes it can bleed. Okay, so some extra pointers, some brownie points, extra topics you are getting on the benign breast diseases. Advanced RACK80 नहीं होता, वो रैकेट कुछ और होता है. RACK80 वो रैकेट वो होता है जो आप लोग खेलते हो दूसरों के साथ, दूसरों के मेंटल स्टेट के साथ. रैकेट वो, not tennis racket. Advanced bipolar energy sources can coagulate vessels directly of diameter. Answer is 7 millimeters. Okay, answer is 7 millimeters. It is the same even for harmonic. Even harmonic can directly coagulate vessels up to 7 millimeters. Okay. So this is your advanced bipolar. This is your harmonic, which is your ultrasonic energy source. How do you differentiate the two? See, in a bipolar, both the poles are the same. The tips of the instrument are the same. But in a harmonic, one tip is going to vibrate. So it is black. The other tip has a Teflon coating. It is an insulated tip. So they are easy to differentiate if you have this common sense, if you have this logic. Which of these manifestations is not typically associated with the given syndrome? Men 1, hyperparathyroidism. So in men 1, you have PPP, parathyroid, pituitary, pancreas, endocrine tumors. One Linda or bilateral RCC is correct. FAP more than 100 adenomas is correct. Lynch syndrome, where do you see lip pigmentation? It is seen in Peutz-Jeghers syndrome. Okay, it is seen in Peutz-Jeghers syndrome. All these images are there in the, all our notes will have these images. So in men 1 syndrome, you will have PTH abnormality. So you will have multi-glandular parathyroid disease. So the person will have hyperparathyroidism. Then you will have pituitary prolactinoma. And the third P, where everybody makes a mistake, that is pancreatic endocrine tumors. And that also, usually the pancreatic endocrine tumor everywhere is insulinoma, but here it is gastrinoma. Okay, not insulinoma. Overall, it is insulinoma, but in men 1, it is gastrinoma. In men 2, two findings are the same. One is medullary thyroid cancer, other is pheochromocytoma. But in men 2A, you get parathyroid hyperplasia. So parathyroid hyperplasia is seen in men 1 and men 2A. In men 2B, you are going to get the other ones. Mucosal neuromas, marfanoid, and megaphone. All of these men syndromes are going to be familial, means they run in families. So their inheritance is going to be autosomal dominant. They will present at a young age. And the tumors are going to be more aggressive. These tumors are because of known mutations. Like how you have BRCA1, BRCA2, FAP, HNPCC, it is the same family. So MEN1, the mutation is in the MEN1 gene, which codes for menin protein. MEN2, the mutation is in the RET gene. Okay, surgery के हिसाब से ये syndrome बहुत है. So whatever I've taught you in surgery, these are the important surgical syndromes. Okay, adenoma can be there, but even if it is adenoma, it will be multiglandular. It will not be in single gland. Okay, Bhuvi, investigation of choice on biliary atresia is on my Telegram. If you want, I can share the photo because there are 2-3 things in it. So I have a picture taken with the reference. Okay, Sida. Like first step, gold standard, whatever words are there, all are there in that reference. So you can check on my Telegram. And it's a pediatric disease. Huh? It's not a surgical disease. 35-year-old man in an inebriated state fell in the bathroom. On examination, abdominal distension was present. There was rigidity. No blood was seen at meatus. No blood at meatus means it is not urethra. So urethral rupture is out because there is no blood at meatus. What is the next step? Chalo, if you are not sure whether it is intraperitoneal or extraperitoneal, any other way of differentiating? Obviously, it's not going to be micturating cystourethroid. MCU can't be done in a patient with a bladder rupture. How will he micturate? So answer will be intraperitoneal rupture because he has peritonitis. And retrograde cystogram. Please remember, cystogram to look for bladder. Urethrogram to look for urethra. Right? Peritonitis means intra, yes, goes more in favor of intraperitoneal rupture. What condition does not lead to bilateral hydronephrosis? A very easy conceptual question. When will you not get bilateral hydronephrosis? Means When will you get both pelvic glycal system dilations? No, not necessary. Vitals need not be deranged. That is in later stages. Any obstruction in this area will cause both ureters to dilate and both pelvic glycal system to dilate. These are sites of bilateral blocks or bilateral hydronephrosis. Anything proximal, like a stone in the right ureter, right PUJ obstruction, will cause right hydronephrosis. So phimosis is penile, urethral stricture, post-urethral valve are all going to be bilateral. Retroureter causes hydronephrosis, not just unilateral. It is on the fixed side. It is only on right side. It can cause only right-sided hydronephrosis. Retrocaval ureter means here is your IVC on the right side. Your ureter on the right, behind the IVC like this, which is in, and gets so the IVC is causing a posterior compression of the ureter, which will cause a right hydronephrosis. It looks like this. This is the image. And this appearance of right hydronephrosis due to a retrocaval ureter, this is called as, what is this called? Fish hook. Fish hook. It is called as reverse J sign. Okay, this is called as reverse J sign. Right? Why reverse? Why reverse means normally J is like this, na? Here the J is like this. The J is more like an L. You can call it L sign, but then L does not sound fancy enough. So they call it reverse J. That is the appearance of the ureter. Because it is going like that behind. Barium swallow in image with regurgitation of meals is demonstrated. What is the management? So what you are seeing here, something is collecting in his neck. Better seen in the lateral X over here. So this is Zenker's diverticulum. It's not achalasia. It's not CA. So it is Dolman procedure. Okay, it is Dolman procedure for Zenker's diverticulum. Okay, easy question. What is the depth of burns? What you are seeing here, pink and moist. Why is it pink and moist? Why is it looking so gila? Answer is superficial partial thickness. Probably here there was a blister which burst. You can see at the side now the skin is a little peeling out. So there must have been a blister which burst, making it pink and moist. IMP question. You will 100% get something of this kind of a question. 100%. Obviously not the same, but on these lines. For that, you need little anatomy. So this first thing that you are seeing, this is the internal sphincter. Uske bahar here is the external sphincter. And what you are seeing, that the fistula is going like this, means it is going through the external sphincter. It is going through the external sphincter. What are these brown things over here? What are those brown things? This brown. It's not feces, huh? Before you say anything. Fat. Fat to yahan hai, yaar. This is the fat. What are those brown things? Nodes. No, not nodes. That is your pelvic floor, levator ani, which tells you that the fistula is going below the levator ani. Means it's a low fistula through the external sphincter. So it is type 2, transsphincteric. Okay. See, suprasphincteric would have also looked like this only that it would have started here, it would have gone up and then down like this. That would have been suprasphincteric. But it still kind of looks like going through external sphincter in photo. So you have to be very careful on this. These are all the 4 types. Okay, these are all the 4 types. Type 1, between the sphincters, intersphincteric, through the external sphincter, transsphincteric, Above the external sphincter, suprasphincteric, and the rectal fistula, that is extrasphincteric. Okay, so be very, very careful about these four images. And this photo has the percentages. Type 1 is most common, type 2 second most common. Okay, which was there in this photo, which you can see a little bit is there. Okay, otherwise you would have seen it. You would have been like, oh, 30% can't be type 3, type 4. The line is joining the cavity as well. In the sense, fistula, it will join the anal canal to the exterior. So it's a fistula. Okay, okay. Easy question. Name of the procedure in the image. So they have removed all these things. Means they have removed pancreas, duodenum, bile duct, and gallbladder. So all this has been removed and the gaps have been joined. Like you are saying, something is joined to the pancreas, something is joined to the hepatic duct, and something is joined here to the duodenum. So this is going to be Whipple procedure. Three joints are there. Pancreatic anastomosis, gastric anastomosis, and hepatic duct anastomosis. So there are three anastomoses. In any surgical image, if you can't identify what is removed, at least see what is joined. The joining will tell you what the surgery is. So here the joining is at these 3 points. So there is a PJ, there is a hepatic jejunostomy, and there is a gastrojejunostomy. That means it is a Whipple's procedure. A 65-year-old male presented with painless hematuria. Elderly smoker male, painless hematuria. Maximum leak is PJ. PJ is the worst anastomosis. All other three are done for chronic pancreatitis. Yes, that is correct. बाकी procedure बता दे. इसके बाद बता दो. He is diagnosed with bladder cancer limited to mucosa, but invading lamina propria. What is the T stage? It is pathological T1. Means non-muscle invading, early bladder cancer. What will be the treatment? Intravesical mitomycin or intravesical BCG. If it was pathological T2 or more, T3, T4, then you would have done a radical cystectomy with chemotherapy. Cystoscopic excision कर दिया ना? He is diagnosed with bladder cancer limited to mucosa. That means it's already been done. Okay. See, in chronic pancreatitis, I am doing surgery only to treat the pain. If the pancreatitis is mainly in the head of the pancreas, okay, he has calcifications in the head, then I do what is called as head coring. Only head core. That is called as Beger or Beggar procedure. On the other hand, if the problem is in the duct, where the duct is dilated, it has stones, it has strictures. In that case, what I do, I take jejunum and help in the drainage of the duct, and I do an anastomosis like this. Duct to jejunum anastomosis. That is called as longitudinal PJ, also called as Pusto. So if duct is dilated, Pusto. If head is inflamed, head coring, that is Beggar or Beger. But if the problem is both, if I do combine head coring plus PJ, that is called as Frey procedure. Okay, where I combine the two. But remember, in the exam, it will be one of these three. But what they will ask you is the purpose of doing these surgeries. These surgeries are only done to relieve the pain. They don't do any functional improvement, because whatever pancreas is gone is gone. Don't say palliative. Palliative is for cancer. It's not a cancer, but it is for pain relief. Okay, first you try other pain relieving tests. If they don't work, then you do this. Okay, recurrence. Recurrence is of course there if the primary pathology is there. If the cause of pancreatitis remains, if he still drinks alcohol, he will get recurrence. This is WAC, negative pressure wound therapy. It does all except reduces edema is correct, sucks the wound exudate is correct, draws the wound edges closest together is correct, but it will promote granulation tissue formation. Okay, it will promote. Draws the wound edges? Yes, it does. So if the wound is this big, by suction, over time, it will become closer. It will become smaller because of the suction. It is true. It's a true statement. It does happen. What is the meaning of extending to lamina propria after biopsy? That means it's a pathological T1 tumor. If it is only mucosa, okay, if it is invading only mucosa, then that is called as pathological TA. Okay, that is only mucosa. That is pathological TA. Right? Okay. This is a PYQ from INI-CET. Female presented to auto ENT with a swelling on the right side of her face. She said that her symptoms worsened after eating food. She had lost her appetite due to the discomfort. What is she suffering from? Okay, you are saying submandibular stones. Why it is submandibular stone? What phenomena she is having? Pain after meals is called as mealtime syndrome. So whenever she eats, the secretions will increase and the gland will swell more because of the stone. And it is seen in this area, just below the angle of mandible. Why it is not thyroglossal duct cyst? Thyroglossal duct cyst is in the midline. Okay, it will be a midline next one. And of course, it will move once she protrudes her tongue. Tongue protrusion, thyroglossal duct cyst will move. TB lymphadenopathy typically is seen in posterior triangle. And of course, pleomorphic adenoma is going to be seen below the ear. Okay, that is going to be below ear lobe. So location itself is giving you so many clues, and I'm telling you, these are the general surgery questions that come in the exam that kill the students. You have to get these right. Okay, I made it a point to put general surgery questions like these because if you get them right, a big burden of surgery is gone. Because these hepatobiliary questions now you may or may not go get. NCCT, yeah, first USG, then investigation of choices plain CT. Biliary pancreatitis is suspected, means gallstone slipped into the bile duct, caused the pancreatitis, which is in fact the most common cause of acute pancreatitis. Would you perform a lap chole? And if yes, then when? Stone from gallbladder went into the bile duct, caused pancreatitis. Would you have to do a cholecystectomy? You would have to do, but in the same admission as for pancreatitis prior to discharge. Interval is not recommended. Why? Why not recommended to do after 3 to 6 weeks? Why do it before he goes home? अभी तो बोलेगा pancreatitis हुआ है. Because in the waiting period, another stone may cause biliary pancreatitis. Today it was one stone, tomorrow another stone. Right? Patient won't come back. That also is true. This is inspired from a NEET PG question. What graft is this? What is this graft? It is a split thickness skin graft. You can see the mesh, the perforations. What nutrition, or rather, how does this graft get nutrition on the first 2 days? Answer is imbibition. It simply means directly from the bed. Okay, directly, imbibition. Like how my good behavior may be imbibed by you, and maybe from tomorrow your behavior will also become good. So you are having some kind of a imbibition from me. It's not inhibition नहीं है, it is imbibition, imbibe. वरना आप बोलोगे आप हमें inhibit कर दो हमारी जिंदगी जीने से. So I'm not causing any deprivation here. Right? So first couple of days, the graft will receive nutrition directly. That's why the bed has to be a healing bed. It cannot be an infected bed like I showed you that burst abdomen. वहां पे नहीं लगा सकते. It has to be a healing bed. After a couple of days, it will start forming some blood vessels. That is called as inosculation. That is going to be from 3 to 7 days. And later it will get proper anastomosis. That is, so it goes like this. This is not from Bailey. This is from Sambiston. Okay, it's not given in Bailey. plasmatic circulation, also called as imbibition, in the first 48 hours. Then some blood vessels start coming. This is called as inosculation. So from the recipient bed to the host, and last mate gets organized. This will continue for 10 to 14 days. So this is the process. NEET PG में similar question आया. What is true about stage 3B, rectal cancer, renal cancer? So Gerota's fascia is T4. Renal vein is T3A. IVC above diaphragm is T3B. IVC above diaphragm is T3C. IVC below diaphragm is T3B. Okay, so T3B is going to be option D. IVC up to diaphragm. T4 is not metastasis. M1 is metastasis. T4 is breach of Gerota's fascia. Because T represents local spread of the tumor, not metastasis. Okay, inosculation means first it is getting direct nutrition, then some blood vessels start joining. Okay, so over time, थोड़े blood vessels from the bed start joining the graft. And after that period, inosculation is over, there is a good vascular connection. But how Gerota fascia is involved later than going to IVC? It is a fact. That's because RCCs will preferentially go directly into the IVC, then into the adrenal gland or the Gerota's fascia. Okay, this is the Gerota's fascia. Tumor is here. Tumor will preferentially go like this. This is T3. T4 is going into Gerota's fascia. It is true. It is inosculation is before neovascularization. Neovascularization is the third stage. Right. A previously 7-month-old male infant suddenly presents with episodes of screaming. Suddenly he is getting pain. He is pale, listless. He has red currant jelly stools, which means he is having intussusception. Okay, he is having intussusception. What is false? There is associated feeling of hardness over right iliac fossa. No, it is empty right iliac fossa. Sign of dance. Dehydration may occur. Can occur if he vomits. Hypertrophies of Peyer's patch is the common trigger. Most common type in children is idiocolic. Other three are straight away correct. Right iliac fossa is empty. There is a sausage-shaped mass in the paraumbilical area. Right. Last question. Patient was brought to the emergency with burns. Deep burns involving, see how kind I was. I have written clearly. Entire left upper limb, 9%. Entire right upper limb, 9%. Nothing to imagine. Anterior aspect of chest and abdomen, 18%. What would it be classified? 36%. So you can't say, but in this that happened and this surface. जो भी है clear cut है. Exam maybe usually burns images, burns questions are like this only. They will ask you clear cut. Okay, cool. Right. So we are done at a decent time. In time, there is no sloughing. No. If there is a burst abdomen, the best thing to do is close the wound if you can. If you can't close, then you go by that. If you can't close it, you go like that. Okay, cool. Fine. आई बात समझ में. Just letting you know one secret that I don't know if you know that I was due to become a father end of April, but Dr. Janvi is already delivered 1 month before. That was day before yesterday. So again, the day you had your class on Wednesday, that same night she went into labor. And I was like, this is too soon. And I was wondering, oh shit, this class again will have to be cancelled. So right now she is in the hospital. The baby is preterm by 1 month. Still, I was like, before they come home, I'll finish with this. So kindly be aware of that. You can message her congratulations if you wish. Okay, it's a baby boy, but preterm, so still in the hospital. Okay, cool. So now you know the secret is out for those who didn't. Okay. So let's see how things go. But at least this course is over. So now I get some time to free my voice while taking care of the child. Okay, guys. So hope you enjoyed learning. We did a lot of surgery in this course, like a lot, even though it's a revision course. हमने करा बहुत कुछ है. Just consolidate it. You will be fine. Okay, just consolidate it and do some practice. Okay, cool. Take care, guys. Have a good day. Bye bye.